for coming into Tony. My name's Dr. Benjamin Lee. I'm here with Dr. Natasha Hunter.
Oh, I have my own mic. We're pros. My name's Dr. Natasha Hunter. I am one of the breast oncologists here at the Hutch, and I'm just delighted to see you all this morning. Thank you all for coming out bright and early on a Saturday.
And and I'm from our radiation oncology department. I'm a radiation oncologist who specializes in breast cancer as well as CNS malignancies. And it is our big honor today to be here with you today. We were approached earlier this summer with a unique opportunity to plan an event for patients. And usually we interact with patients in the office during clinic visits. So for us, this seemed really novel. And I know it might sound kind of silly, but like, whoa, we get to talk to patients? Over coffee, yes. But what is special about this event is it's for metastatic breast cancer patients and their caregivers. And we know that when someone has a diagnosis, it's not just the patient that's involved, but it really is the whole village around that patient. So first of all, we were given permission to design this conference however we wanted, which was amazing. And we both kind of were on the same wavelength. We wanted to make something that I don't think we had seen before, something that is really, really practical, puts ourselves in your shoes, and tries to think of, okay, what are all of the different domains that I might be going through, and some things that I never had formal education or presentation, stuff I've had to figure out on my own as I've gone through it. And I think as an academic institution, it's our duty to try to continue to support you even after you leave the office. So this is a growing landscape, you know, the what does it mean to focus on survivorship? And we wanted to have some fun with this and think about not just surviving, but thriving. And funny enough, this is something that we also think about as doctors. Don't just survive, but thrive. So as you see here, we have an outline of the speakers today and the different topics. And we go into things as practical as finances, financial planning, dealing with medical bills, stuff about living at home, changing relationships, sexual health, coping with some of these changes. And self-care is a really big aspect of living. It's everything that's happening after the doctor visit and in between. And there are many domains of that we want to touch on today. And then we have some really special speakers today who can speak to both sides of the picture, both from the physician side, but also from the patient side. And I think sometimes some of the strongest insights come from that unique overlap of spaces. So you'll get to hear from two amazing guest speakers today. One who's my mom. And then lastly, Dr. Hunter and I will give you our rundown of clinical trials, hopefully not in a very boring way, but kind of an exciting way to finish on a high note. And we hope that at the end of this conference that you will have some tangible takeaways across all of these different domains to make your lives better.
So just a few housekeeping housekeeping things. First of all, I do want to welcome, we have a lot of people here joining us in person, but we also have, I think, at least as many who are joining us virtually. So I want to welcome those folks. We have a little laptop set up over there that Ben and I will be shuttling between to follow the chat and enter any questions that come up from the virtual audience. So welcome to those folks as well. We're happy to welcome all of you. It has been just my delight and pleasure to plan this with Ben. The event, as you know, is recorded. I think that you signed a waiver when you came in to allow that to happen. It won't be used for commercial purposes, but it is something that we want to make available. For virtual attendees, do post your questions in the chat function. You won't be able to chat with each other, but you will be able to chat with us, the moderators. And so we can respond if there's anything urgent to respond to, or obviously if there's any sort of technical issues, and then we will share those questions that you post in the chat. In terms of all you folks here who are with us in person, if you could please hold your questions until the Q&A sessions. Each section will be followed by a Q&A. So they're sort of topic groups, and after each speaker, after all the speakers in a particular kind of topic speak, then we'll have a period for questions and answers. The staff will be circulating with microphones like this one to allow you to ask questions. It's going to be important for you to actually ask questions in the microphone. Some of you have loud voices, I know, but we really want the virtual attendees to be able to hear, and the only way it gets recorded is if you speak into the mic. We also, because as part of this, we didn't want to just be speaking at you. We want to hear your stories too. We want this to be an opportunity for you all to meet each other and also to hear from each other, because I think that one of the things, so one of my research interests is metastatic breast cancer and the experiences of people living with metastatic breast cancer. I did a series of focus groups talking with folks about their experiences and recorded those interviews. And I learned a lot from it, sort of from a research standpoint, but also just hearing people's actual voices and stories was really incredible to me and was moving to me. And I think these are important voices to hear. That survivorship community is important to listen to. So we wanted to give you folks an opportunity to speak. And so we do have a recording booth set up. And a sign-up sheet. We have some question prompts just to help you kind of focus your thoughts. We wish that we could just hear all of your stories from beginning to end, but unfortunately we don't have time or bandwidth to do that. And so if you could look through some of those prompts and think about kind of what resonates the most with you, what are some of the stories that really stand out that you want told, and then we'll have an opportunity to record those. You don't have to be, a news anchor to record them. It's just you telling your story. So in that, is there any other housekeeping stuff? Oh, thank you. Ben's got my back. So this is obviously, we want this to be a meeting and a day to talk about life and taking joy in life and really finding your way forward with a metastatic diagnosis. However, we know that this may bring up some deep emotions for folks, and we also want to make sure that we allow you to kind of express those, or to also, if you need to step out, if what you need is sort of to get away from all of this, that's also completely fine. So if you are encountering some difficulty hearing any of these talks or any of these stories, please feel free to step out. We understand that these are some difficult topics, despite the fact that we're really trying to focus on the, taking joy in life and being, and really surviving and thriving. We also know that it can be emotional. So please feel free to step out if you need to.
Great. And then scan this QR code.
We have a new metastatic breast cancer page that we've been, that has been the result of an incredible amount of hard work by the Hutch staff, but we've also weighed in on it. I think it's fantastic. So that's the code for that page. We're really pleased about it, and we're excited that this conference may be one of the first things that appears on the page, information about this group. So, all right. We're not actually taking a break right now, so don't run out.
Yeah, and I think we are ready to introduce our first speaker, keynote speaker.
So I have the distinct honor to introduce my friend, Shaveta Vinayak, Dr. Shaveta Vinayak, who I met. She was one of the first people that I met when I came here to the Hutch in 2018. She had also come here shortly before I had and joined the breast oncology staff. I worked with her as a close colleague and friend for several years with her, and she would see me darkening the door of her office all the time, asking her clinical questions and what should I do. And so she really was a friend and a mentor to me throughout that time. And in terms of sort of seeing patients and also in terms of research. So we really developed a close friendship. And I also developed a lot of deep respect for her professionally as a breast oncologist and as a breast researcher. So I am so thrilled to be able to introduce Dr. Shaveta Vinayak as our keynote speaker today.
I can use this microphone, right? Good morning. Can you guys hear me well? All right. Well, I'm Shaveta Vinayak. I'm here as a cancer patient today, like many of you in the audience. This is a very special day for me, as it is the first time that I'll be sharing my cancer story publicly. I want to thank one of my dearest friends, Dr. Hunter, for that. I may get emotional, so please forgive me if I forget my words or lose my train of thought. It'll be intensely personal. I'll be sharing my reflections, writing, and artwork directly from my journal. You may connect with it, you may get uncomfortable, or it may cause you distress, but I'm ready to bear it all. So here it goes, My Big Fat Metastatic Life. This is a title that my son came up with. My story started in 2011. While training to be an oncologist, I became an oncology patient myself. At that time, my family son. I went through treatments for early stage breast cancer, including chemotherapy, radiation, mastectomy. I did it all. Started an endocrine therapy, had additional surgeries, got my ovaries removed, and I did everything possible with the goal of putting this cancer thing behind me for good. I rebuilt myself. I felt like, a phoenix coming out of the ashes. Physical health, mental health, emotional health. You guys know it all. And then I had to hit pause. I was in my oncology fellowship. I had just completed 2 years of it. I was in sort of the research phase of my fellowship at Stanford at that time. And then I thought, well, should I continue my oncology training in breast cancer or pivot? I had already dedicated some time to breast cancer research. I loved it. I was very passionate about women's health since I got into medicine, even before medicine for that matter. And breast cancer it connected with me. I loved data, I loved science. I just loved the clinical trials and all of the evidence that we had collected so far, and I wanted to make a difference. And after my breast cancer diagnosis, something just still kept pulling me towards breast cancer, and I couldn't leave the field. But it was not easy coming back. My thoughts were, would I be able to handle seeing patients with the same disease that had really just wrecked me? I had to take it slow. I had to make that decision thoughtfully. I started this shadowing in breast cancer clinic, just like a medical student again, even though I was much further along in my training. In the early days when I returned, my mind wandered. I couldn't help myself. I kept worrying about the patients in my situation. I worried a lot. I took a lot home with me. But as time went by, it got better. I shadowed in clinic, and then I decided, well, I think I'm ready. I was ready to dive back in. I was able to compartmentalize in a very healthy way. I had some tools in my box, and I moved forward. Some things still hit me harder in clinic, such as younger patients with kids, patients who recurred despite doing everything possible, and patients who were dying of their disease. But at the same time, I felt truly exuberant about all the good news that I got to deliver. It felt like a privilege. It was so amazing to just see each and every patient come out on the other side. It felt meaningful to really help my patients make the best decisions for their cancer treatments. Research felt purposeful. And discovering and offering cutting-edge treatment options to patients just felt great. Now we're going to move forward to 2022. So fast forward 11 years, I was still on endocrine therapy. I noticed mild shortness of breath with exertion, and it went on for a few weeks. It seemed unusual given that I had felt more fit than in the last decade. I saw a cardiologist, and I had a heart test. I thought it was my chemotherapy that I got. I had gotten adriamycin. I was like, what's going on? I couldn't explain it, but the heart test showed a large right pleural effusion. That means my lung was filled with fluid. And that probably explained my symptoms. I was like, that makes sense. I was in the cardiologist's office, and as soon as I heard those words, it felt like silence. I couldn't hear anything else after that. And I was like, no, I'm not taking this. My mind went numb. My heart started racing more than ever at that appointment. It was Friday the 13th, May 13th, 2022. My poor husband, who was with me, had no idea what had just happened. He's an engineer. Yeah, so had a lot of explanation to do afterwards. And he hates medical stuff more than anything else. But he knew. He had been through it all in 2011. He knew something was wrong. My facial expression said it all. He knew it was very serious. I got myself to the car. My cardiologist sent me for blood draw. I kept it together. I remember coming down the elevator, keeping it together. There were so many people in that elevator, I just couldn't wait for the elevator to get to my car. Just kept myself composed, and then I got in, and I just sobbed. I probably sobbed for hours. In my mind, there was really only one possibility. My breast cancer was back, and it had spread. Nothing anybody said mattered. I knew it just couldn't be any other diagnosis. I'm an oncologist. As much as I did not want that diagnosis, I knew it was it. All my tests confirmed this diagnosis, and I've been on treatment for metastatic breast cancer since then. So before I share my cancer journey, my reflections, I want to put out a disclaimer. I am not a therapist, social worker, or psychiatrist. I'm a cancer patient and a medical oncologist. So please take everything that I say with that in mind. I'll be sharing my own personal experience and insights through this journey, which may be unique or shared. We'll find that out. So how did I feel at the beginning? I felt isolated. I felt alone, even with so much support. I have an amazing, incredible family and friends. My community of oncologists are incredible, but I felt so alone. I felt shocked. I felt like my world had just shattered all over again. I felt like I did this 11 years ago, but it felt just, my heart went to pieces in a very different way. I felt I can't do this. There's too much grief. I just want to escape. I want to get out of here. Every time I went to the airport, I wanted to take a flight to some place where nobody could find me. And my questions were, will I live? How long? How do I plan for anything? Of course, I thought about every single one of my patients with metastatic disease who had asked me the same questions. And I didn't have very good answers. We always talked about just taking things one day at a time. Sounded so cliche to me. I'm like, I want more. I want more specifics. I have a family. I have my work. How do I navigate all of this? This is how I felt. This is from my journal. There's, you see that big cancer monster? And then there's a little me stick figure in the bottom. I'm tiny. I felt powerless in front of the cancer monster. I'm still wearing a crown though, by the way. I want to make sure you notice that. Because I'm a princess warrior. And I'm not giving that up. So I felt, I talked to the monster because I didn't want to take it out on people. So I said, go away, never come back. This is how I felt at the very beginning. I hate you. You're ruining my life. You're ruining what I've worked so hard to build. You're taking everything away from me, including people. How can I live with you with all the chaos that you're causing? I don't want you in my life. Get out. And then I moved forward. I had to figure out how to navigate all this. I started to set my intention. I decided I will focus my time and energy on what and who matters. I still want to live a life on my own terms, and I wanted that more than ever before. I wanted to continue to live a life of meaning and purpose. That was important to me. I just wanted to let all the unimportant things fall away. Peace became really important to me. I couldn't do it without that. I wanted to protect my peace in all aspects. I felt like peace is limited through this journey. And I wanted to protect it so it can grow. And then there was work. What should I do about work? Up until my metastatic diagnosis, I was a practicing oncologist. I appreciate some of my patients who are here today, and it's been very heartwarming to see each and every one of you. And I was a researcher focused on triple-negative breast cancer. I had to make some decisions, some really tough ones. Should I keep working? Should I go on disability? Of course, I had no idea how I was going to do. My lung was filled with fluid. Didn't know if I was going to ever breathe normally again. Was it just going to keep coming back? Was I going to need a drain? Was I going to respond to treatment, and how long? I had so many questions. I'm at this great, amazing, large institution, Fred Hutch and University of Washington. I still had difficulty navigating the work situation. At the end of the day, it was really individuals I had to seek out who helped me and guided me. There wasn't one office that I could go to get the guidance that I needed. To be honest, that was alarming. I felt that in that very tumultuous, shocked phase in the beginning, on top of it all, I had to figure it out. I went on 3 months of medical leave, and there are so many decisions I had to make. And then I was, tried to be thoughtful about it, but I wanted to know, how will this work decision impact my finances or medical insurance? Is this really the end of my career that I've worked so hard to build? I felt young, maybe I'm not so young, but I felt young and I had so much more to give. But maybe I don't have the time, maybe I don't have the energy. I just didn't know. And then how do I disclose my diagnosis to my colleagues, and how much? Was there a safe space to be vulnerable? Those are still questions that I grapple with. So the work decisions I've made so far, I did stop seeing patients after my metastatic diagnosis. That felt right to me after thinking about it for months, but it felt a huge, huge loss. It left a very deep gaping hole in my heart, and the patients who are here today, I hope you know how hard it was for me to leave my practice. I have been doing research and developing clinical trials with the University of Washington Cancer Vaccine Institute, and having that opportunity to be productive in the cancer space has been very meaningful. Some of my colleagues are here today from the Cancer Vaccine Institute, so I do want to give a shout out to them for just being here and supporting me. And that's Kieran, Jen, and Gina. There have been challenges in personal relationships. So, have any of you guys been cancer ghosted? Raise your hands. All right. Well, I have. My advice, don't waste time thinking about it. Don't try to figure it out. That's somebody else's problem. Not everyone has the capacity or desire to deal with your illness. I have learned to just meet people where they're at. Some of them can be just your fun friends, and they can still be in your life. You get to decide that. I have had some tough relationships and conversations, including some close ones, and have had to let go of some toxic people in my life. It's been very hard. But I've had to set my own boundaries, and I encourage people to set them and don't be afraid to do so. Relationship lessons that I've learned. For me, having authentic, honest, and deep connections continue to be very important through this journey. I try to be there for whoever is important to me. I try to be clear about what I want from people. And this is for the caregivers in the audience. Patients may feel sad, angry, frustrated, lonely, or just plain old tired at times. They may not want to talk to you. They may not return your calls or texts. That doesn't mean they love you any less. They just need some space to process what's going on. I am very clear with my husband about that. And I take the space that I need to do my own things. And so does he. And we're doing much better navigating this space now. Processing grief. This is something that was very hard for me in the beginning, and I actually had lots of conversations with Dr. Hunter at a cafe about how do I navigate this? I felt I wanted to be on the same journey as my family and wanted to solve all their problems and everything that they were going through. And I definitely did not know what I was doing. I just wanted to figure it out and, have a solution to everything. That didn't work out very well. So then I learned that everyone needs their own space and time to process their own grief. We have the journey together with our close ones, but a lot of it is solitary too. So I think it's a solitary path for some, and get your own therapist if you need one. Even with all the support in place, I think being a patient to me, and I'm going to have a lot of visual stuff in here because that's just who I am. To me, it feels like being on an island alone and just kind of dealing with my own and everyone else's grief at times. And I feel like there's all these other people in the sea, but they're together. And those are the loved ones who anticipate being left behind, but they still have each other. They're together. They can relate to each other. But my feelings are different. Sometimes I can't relate to theirs or they can't relate to mine. So in personal relationships, this is from my journal. I wrote, let go of all expectations. Just meet people where they're at. Medical challenges. While feeling ill, you're still learning to navigate your provider, team care, and communication. You're trying to figure out the best treatment plan, maybe getting second opinions, maybe considering clinical trials, and you have to travel for that. You're still dealing with side effects of cancer drug and symptoms of cancer. It's a very special day for me today because I'm here. And as Dr. Hunter knows, this last month has probably been one of the most horrible in my journey. But things turned around last week, and I was meant to be here today. And then dealing with insurance to get drugs. Whoa, geez. I wasted some time on that. Spending time traveling to and at appointments. Yes, I waited 3 hours for a second opinion at one time in New York. My friend wanted to leave, and I was like, no, this is normal. It's okay. We're here. We're not going to leave. And while you're working and taking care of other obligations, there are other aspects of your life you're still taking care of. It's just not the cancer stuff. So I'm going to just share with you in terms of one of the medical challenges, how I felt about starting chemotherapy. I had just come off of Ibrance and fulvestrant. I thought, oh, I have a long ways to go before I have to consider chemotherapy. There's certainly other options. I had had chemo before. It was not my first rodeo with chemo, but somehow it put me into a really dark space. I was just not ready. I felt like I wanted different options before I embarked on the chemotherapy journey. It led to some dark weeks, and this is straight from my journal. This is me, again, a warrior, a pink warrior, with all the armor in place. And I got these little, I don't know if the arrow shows up, but these little boxes, which is basically lead bricks protecting me, and all of the stuff in place, but somehow the needle is still getting through and drawing my blood. And I got the capecitabine pills up there with the C, and they're still gonna get in. I couldn't protect myself. I had to just give in. And there will be darkness. We write out the dark days. This is again me. Stick figure at the bottom, crying tears of blood in a pool of blood, with really big boulders on top and barbed wire on top. And nobody can see me and nobody can hear me. I'm trying to tell you, this is not what I want, but you're not hearing me. I have to just sit with it. The darkness, I have learned, again, to just sit with it. Let my life get derailed. Just let it happen. I think cancer chips away pieces of us, but it also allows us to mold in new ways like a sculpture. How do we face uncertainty, which is such a huge part of this? Everything feels like a question mark. I feel the pressure to make everything meaningful. I regret when I have conflicts and arguments. What if it's the last one? What if I never see that person again? I try to live my life between appointments. I try to live and plan in chunks of time. And I'm still traveling, and I've learned to make travel plans very quickly. Right after my diagnosis, before I even had my first scan, I planned a trip to Italy for my family. I surprised my son just because I was feeling a little better. And we went on a 10-day trip. I climbed the Duomo in Florence, which I thought I might not be able to do. I had told my son and my husband, you guys go, don't wait for me. I may make it a third way, halfway, or to the top, but they waited and we did it together. And I made it to the top. Who knows if my lung was a third or half filled with fluid at that time, but it didn't stop me. With all of the breathing issues, I made it up there. And that felt amazing. So what depletes my energy? Sad thoughts related to cancer and treatments, dealing with medical care. Yes, I know I'm an oncologist. I remind myself that once in a while. Dealing with side effects of cancer drugs, dealing with cancer symptoms. That's been a doozy in the last month. My work is still all cancer related. That's draining at times from cancer. Challenging relationships that drain me. And there are things that I will always feel gutted about. I'm just not accepting them, and it's okay by me. No amount of therapy is going to fix this. I can't find peace around missing out on my son's life. There's anticipated loss of time with family that still causes unfathomable, gut-wrenching pain. And I'm not going to get over that. It's not fair. I still continue to have struggles. How to live in the present. Am I living my best life? What's still on my bucket list? I got to prioritize that. What will my legacy be? And for me, grief and gratitude go hand in hand, and that's something I have learned to accept, and it gives me a lot of strength. I've learned to find my anchor, to find stability and feel safe. Again, I'm a visual person. These are things that help me process my grief. I feel safe if I can find my anchor and find stability, because I can open up. It also allows others to hop in my boat if I have a stable boat. Come on in, let's chat. I've found some external and internal anchors. Nature, exercise, connecting with friends and family. Those are all my external anchors. Those help me get through. Internally, I'm strong. I know who I am. I know my priorities. I know I can rely on myself. I can ride the storm. I have the ability to adjust and adapt no matter what comes my way. I'm capable of sitting with pain. I remind myself storms are temporary. I have the ability to find what I need. I'm resourceful. And then what repletes my energy? Being in nature, fresh air, spending time with friends and family, traveling. I have a collection of baby succulents since my diagnosis, and it's been growing. I love taking care of them. Home interior designing. On top of everything, my husband has been renovating our house for the last 2 years. He thought it was a good time to do that. Reading, exercising, great food. So if you have any restaurant recommendations in Seattle, pass them along. Gratitude, and just taking a pause in life. Finding meaning and purpose. That's been a big one. Life as I knew it may be over in many ways, but through the cracks, new life can be born. I think about those pesky little plants that grow through cracked concrete, and I find them in nature, and I love seeing that because that gives me hope, and I think about new life. Ask me how I want to live, not how I want to die. This is my dream for oncology teams across the world. This answer will help guide my treatments and give me the best possible care. I want you to ask me my preferences in treatment. I want you to ask me if I want to participate in trials. I want you to know what matters most to me. We will get to that conversation about dying, but can we hold off on that for now? Now that I'm 2.5 years into my diagnosis, the monster is still there, and I'm still here. We were never going to be friends. We were learning to coexist, still not letting it take over my entire existence. I can ride the waves of progression a little better than when we started. And all that is unexpected, because guess what? Unexpected is to be expected in cancer. I don't need to be a cancer warrior all the time. It's exhausting. Sometimes I just need to write things out and have lots of faith in my team and everybody else around me. I'm learning to try not to overthink. That's hard. I'm also learning that it's okay not to have control. And this is a Persian adage that my son and I say to each other all the time: this too shall pass. I'm still here. So I want to make my life matter, stay productive in whatever way I want and can. I want to continue to build deep connections with people, continue to build my life of service, keep finding new purpose, keep redefining meaning, keep traveling, reading, eating, planting, more than succulents, I hope, smiling and really just enjoying life. And as cancer evolves, so will I. Because why not? So keep on swimming like little Crush from Nemo and savor the good, the bad, and the ugly of life. This is me in my travels since my diagnosis, eating good food and trying to live my big fat metastatic life. I'm so glad that we're all here, and thank you for coming. Thank you.
Thank you so much. I think we have time for a few questions. I'll share just to begin with that there are some comments in the chat. One comment in particular, wonderful presentation, which I completely agree with, obviously, but also congratulating you on making it to the top of the, what is it, what did you climb in Italy?
Domo.
The Domo. So congratulations. A few more comments that in the chat that I would describe as pointing out some of the differences between different people's experiences. There's a young person commenting in the chat talking about how unfair it feels that she has been deprived of certain experiences, or she anticipates being deprived of certain experiences in life, including partnership and family, children in particular. So there's one comment like that. And then a few others just really resonating with your experience, a few diagnoses that came about in a similar way to yours. And then also really loving the expression of how do you want to live rather than planning for death and end of life.
Thank you, Tasha.
Is on. Hi, I've had this question in my head for the last year and a half or so since I've been diagnosed, and I was wondering about a lot of people, it feels like, who have metastatic breast cancer, it was a recurrence from a much early stage cancer. And so I was wondering what was the protocol now and what was the protocol like 15 years ago, that once you got through your early stage, how you were, what was the protocol to follow up? Because going from stage 1 to stage 4 seems like a huge jump.
I was not stage 1.
Okay.
I was stage 2, but it's the protocol and what I'm, in terms of, I feel like what you're asking is like, in terms of the monitoring that happened maybe 15 years ago versus now, that has not changed. We don't have any evidence to do, scans or blood work, tumor markers, any of those things. I'm putting my oncology hat on. Any of those things for monitoring. 15 years ago, we didn't have that evidence and we don't have it now. So yes, in terms of, recurrence, we still rely on symptoms and exam. I know that seems like, what, couldn't we do more? I think eventually we're going to get to hopefully some circulating tumor DNA technology, and there's lots of other things that are coming for monitoring, but nothing has changed yet in terms of standard of care. I don't know if Dr. Hunter wants to add to that.
Said it beautifully.
What are your feelings towards Enhertu?
I haven't been on it yet. I think my feelings are based on the clinical data that's been presented, and it seems like a great drug. It obviously requires some monitoring for, inflammation in the lungs, like pneumonitis, blood work, and things like that. But in terms of its successes, for HER2 low, HER2 positive, it seems like a really great drug and been pretty successful in controlling the disease.
Hi, I realize you're not a therapist, but I found your presentation very therapeutic, so thank you.
Thank
And
you.
I'm wondering, will your slides be available for us to view like as a separate PowerPoint? And I know there's some very personal things, you're welcome to take those out, but some of the things you shared, I think it would be really helpful to kind of go over with my family. I think it could start some great discussions and open some conversations that would be really helpful. But even if it's not, thank you.
I can definitely make an edited version of this for public viewing and downloading. I'm going to just take out some of the personal stuff. Yeah.
Ditto. Because I also was diagnosed like 23 years ago, and then it came back.
Oh,
So, but my son, the first time was 14, and now he's 38. And didn't you find when you had it the first time that you already kind of did the part of your personal spiritual journey then? So that when it came back, I'm having a really hard time getting past. In fact, you made me cry when you're talking about, I call it FOMO. I have serious FOMO, fear of missing out. And also ditto on the PowerPoint, because I would love to share that with my son and his wife, mainly because I don't think they understand where I'm coming from. Because if you're in a, like I worked in pharmacy. So when you're in a life of service, they don't quite understand why I want to come up and help clean house. Things like that, because you want to be of service still.
yeah.
So anyway, I was just curious, if you ever come up with a way to get past those two things that you can't get past.
I don't know if I will, and I feel like I'm not even working on that. But in terms of the answer to your first question, I actually just dived right back into work. I don't think I processed my diagnosis in a spiritual, emotional way the first time around. I felt like I got this. I am an oncologist. I was like, just dived right back into work, and I felt like I was doing well. But with the diagnosis becoming metastatic, I definitely felt like all those feelings came back and I had a chance to process them a lot better in 2022.
I think you were holding up the sign. Yes, I did find that person. You don't want to interview anymore. Okay, yeah.
I'm just wondering, on top of all of that, which is huge, that you are dealing with, in being a woman of color, how much did systemic racism play into that? And how do you deal with that? I've been dealing with this for 20 years, and as I tell people, I am so tired,
Yeah.
and you being a doctor, you were able to get over some of that, but did you
Yeah.
run into any of that?
I think that's a tough one, and it's something we are actually working a lot on from clinical trials perspective. I actually have a grant where we're working with the community sites to increase diversity in clinical trial participation. And I would say for me personally and professionally, that is one of the most challenging and hardest things to deal with because people of color, BIPOC, are so underrepresented in clinical trials. And me being a researcher and having dedicated my life to clinical research, I feel like clinical trials are opportunities. Whether you want to take advantage of them or not, every single person needs to have access. And travel barriers, financial barriers, they need to just fall away. People need to have access and have that opportunity and the choice to participate. And that is a huge passion project of mine, and we're working through that. Of course.
I've heard that quite often, and I agree, people of color are not participating. But in 20 years, 5 occurrences, I have never had my oncologist suggest a clinical trial.
And that's shameful.
Yeah, but that's the kind of thing
And
we deal with.
Yep, and that is something I think there's an implicit bias, that's what it's called, when you're not even being offered sort of the best standard of care, and that includes trials. So I'm gonna just say that's shameful. And I hope that doesn't happen here.
In the interest of staying a little bit on time, I'm afraid we'll have to cut questions off for now, although Dr. Vinayak.
I'm
will
here
be
all day.
All day. So I
Thank
can't
you, guys.
thank you enough.
Next up, we have Dr. Christopher Sue, who has so graciously taken some time to join us today. Dr. Sue is an oncologist here at Fred Hutch who has a career passion in cancer disparities. He has particular experience in financial toxicity and also helping cancer patients who may have disparities related to English as a second language. So Dr. Sue, we're so happy to have you here with us today.
Thank you very much. Thank you very much, Dr. Lee, and to the event organizers for inviting me here. So very nice to meet you all. What a great talk just now. I was very touched. So my name is Chris Sue. I'm actually a blood cancer oncologist, but I spend most of my time doing research, looking at financial burden experienced by patients with cancer and working on solutions to help them through the cancer process, because it can, as many of you know, it could be a very, very long process. So today I'm going to be talking about financial toxicity, a term that you may be familiar with, and some potential helpful resources that might be of service to you. I want to point out one thing. So this is a news clipping from the New York Times in 1997. Financial toxicity has been around as long as we have had cancer treatment for cancer. So this is definitely not a new thing. We're just really putting a name to the problem and really systemically thinking about solutions to this issue. So what is financial toxicity? The official definition of this is the unintended but not necessarily unanticipated objective financial burden on and subjective financial distress experienced by patients with cancer as a result of their treatment. So I want to point out a few things here. It's unintended, but not necessarily unanticipated, meaning that if we know that this is going to happen, we can take steps to prevent the negative consequences from happening. And there's two components. It could actually be just the money cost itself, but there's also a component of distress, the anxiety, the worry that you might feel about unaffordable bills, for instance. This summer, we spent a lot of time about talking to Fred Hutch patients, 30, 40 of them, about their experiences affording their cancer care. And here are some of the quotes that I'm going to sprinkle in this presentation. So one of the participants told us, "I'm in debt in a reverse mortgage with my home, but I don't use the money, and I don't need the money to live on, not at all. It's a hedge to take care of the unexpected costs related to my having cancer because I don't have people. I don't have any children." Some people will say, well, my kids will take care of me. Well, I don't have any kids to take care of me. So here we have somebody who actually mortgaged their house because they're so worried about the cost that they're going to have with their ongoing cancer treatment, which is, very sobering for us to learn. So the most common thing that people think about when they think about financial toxicity is the cost of drugs. And that's actually the most common thing, but there's so many other things. So I'm just going to pull out a few things here. So, on one hand, we have this expensive oral cancer drugs. There is this medical Part D thing that I put in here. This is an old slide, but I kept it here on purpose because folks, some of you here are on Medicare Part D to pay for your prescription pills. It has changed a lot in the last 2 years in terms of how much you have to pay out of pocket because of President Biden's Inflation Reduction Act, which I will talk about a little bit later. But before, you might know personally that you're responsible for this ongoing payment, and it can be a lot. And so that has actually changed in this year and in the years going forward with the legislation. So I'll talk about that a little bit. There's other costs about, having to go to lab, getting your blood draws, coming here to visits a lot. You might have a copay associated with your visits. There's transportation, food, lodging, any other medicines that you need to control your symptoms. Just because of having cancer, you might not be able to work as much as you were able to do before. So then there's the job loss, there's lost wages, there's lost opportunities. People tap into their savings. They might take on debt and loans. They might lose their credit in the process. And in severe cases, they might have bankruptcy or go into foreclosure. And we talked a little bit about the psychological effects of financial toxicity. People often tell us they don't feel productive. They have family tension because there's so many bills. They feel hopeless. They feel suicidal even. And all of this, then goes on to, needing counseling or therapy, which could ironically impose more costs on top of everything that's going on. This is a very busy slide. I'm just going to really point out here this red box here. And this is what we're really trying to study and trying to prevent. We don't want people to borrow money. We don't want people to be depleting their savings to pay for their cancer care. If there's a way that we can get people to not do this and to not suffer the consequences of financial toxicity, that's our research and that's what we're trying to work on. So this is all just research. What is actually helpful to you? So I included some information here about some helpful resources that you might be able to use or think about. Many of you might be intimately, aware of these things because you had to go through the process of figuring this out. But to others, I hope it might be of help to you. The first step before I say anything else is to start with your designated social worker or patient navigator. They are the hub to all of your resources. We have very great social workers and patient navigators here at the Hutch. If you need help connecting to them, please speak to your cancer care team. They'll be happy to connect you with somebody. I work with them a lot and I know that they're excellent. So the first step is to always start there because I just can't possibly cover the entire range of possible services that you might be able to access. So first, I'm going to talk a little bit about high drug costs. So here's another quote that I found very sobering from one of our participants. I had no idea that a medicine can go from free, meaning a $10 to $20 copay, to $250. They could set their own price. I didn't know they could do stuff like that. My own going through that experience was very frightening. Jesus, I could die from this cancer because I can't get treatment. So if you need help with out-of-pocket drug costs, the first thing that you need to do, and I think our social workers are actually pretty good at this when you come in here, is to optimize your insurance coverage. Insurance in the US, as you know, is very complicated depending on whether you have worked, where you are in terms of your work trajectory, and then your age, whether or not you qualify for Medicare, different types of Medicare, Medicare traditional, Medicare Advantage, and then if you don't have a lot of assets, then you might qualify for state assistance and Medicaid. So it's very, very complicated. We can talk for an hour about what types of insurance is available to you. So the first step is to really talk about this to your patient navigator. One thing that a lot of people don't know about that if you are Medicaid age or above, so if you are eligible for Medicare, not Medicaid. If you are eligible for Medicare, meaning that you are 65 and above, Washington State actually has this really nice resource called Sheba. They're actually these like free counselors that you can just like call, or if you prefer talking to them in person, they're usually at churches or community centers during the weekday and sometimes on the weekends. And they know everything about Medicare. They can tell you where you are at, what type of Medicare is the best for your situation. And a lot of them are even patients themselves, and they have gone through the process, and then they got trained to become these advisors. I've spoken to a few of them. I really like them. I think they're very knowledgeable. So if you are Medicare eligible, they're a great resource. You could just go online, type Washington State Sheba. But you have to be 65 or above and be eligible for Medicare. They don't help you with commercial insurance. So a lot of you guys might be familiar with pharmaceutical assistance programs. These are programs administered by the drug company. They basically provide drugs to people who need them and don't have a lot of assets. This usually, your cancer care team will help you access. They're administered directly by the drug manufacturer. They typically require your proof of income or tax returns. I think we're pretty good at getting people on these drug assistance programs if they need them. So I'm not going to talk about too much here. There is a lot of cancer center and foundation assistance around unaffordable drug costs. So if you're maximally assisted and you're still having issues, there's the Patient Advocate Foundation. There's Leukemia Lymphoma Society for blood cancers. And then, I'm sure there's an equivalent for breast cancer as well. And then there's also, other funds and programs available if you just reach out to your care team. I listed some websites here that might give you some drug discounts or coupons, if you want to check on something that you feel like is very unaffordable to you. So I said I'll talk a little bit about the changes in Medicare Part D. I think this is very important. So before in the past, that's really all the way on the left-hand panel, 2023 and before, you pay $3,100 out of pocket, and then you're still not off the hook. For all of your expensive drug costs, you're paying 5% of whatever whatever that drug is from January all the way to December, and that never ends. So you have this copay that you're just constantly paying and paying and paying. So President Biden 2 years ago signed into law the Inflation Reduction Act, and it actually put a cap. It got rid of this. You see how it says there 5% enrollee? It actually got rid of that. So now you're responsible on Medicare Part D for a flat copay out of pocket. And then once you meet that cap, you don't have to pay any more for your prescription medications if you have Medicare Part D. So this is a major shift, especially since we know how expensive some of these oral pills for breast cancer can be, major shift. So this year, the cap is $3,250, and beginning from next year and going forward, it's going to be a flat $2,000. So this is actually a very, a very big change. And I have some folks that I talked to, they're actually shifting their commercial insurance to Medicare because of this, because they actually save more money on Medicare Part D. So I would say that this is something for you to think about if this might apply to you. Hospital bills. One of the patients we spoke to said, one thing that I think I am, I've always been a great payer. I will put my bills before I eat. I will literally go hungry before I will miss a bill. The reason why that is if I can't pay my medical bills, then the hospital is not going to treat me. I feel very sad when I hear a patient say this, because this should not be the case. You should not go hungry because you think the hospital is going to not treat you because of your medical bills. There are solutions for this, and you need to talk to somebody if you are in this situation. Washington state law actually mandates charity hospital care, basically free, no out-of-pocket cost, period, for patients and families making less than 300% of the federal poverty level. And you get discounts if you make 400% of the federal poverty level. I can list all of the amounts here, but for some example, I've listed the 2-person thresholds and the 4-person household thresholds. There is an application process for this, and details about this charity program is not readily apparent, even though this language is required by law to be printed on billing statements. I think Fred Hutch as a whole, we're pretty good at making patients, helping patients address hospital bills if we know that there's some financial difficulty. But there are a lot of health systems here, even in Washington state, they don't advertise this. They don't tell you anything about this. They just send you bills in the mail. And then, patients get very flustered, they get very concerned, and then, they go hungry because they're afraid that the hospital is just going to cut their care off. Hospitals do require you to apply for maximal insurance coverage. So basically, if you're eligible for Medicare or if you're eligible for Medicaid, you need to apply for that. And then the hospital will cover whatever you have left over after your insurance kicks in. If you don't complete the application process for insurance, hospitals are not obligated to provide you with discounted care or free care. So this is a caveat, but usually I think people are okay with applying for insurance. If you have any remaining bills that you're worried about, please, please, please reach out to the billing department of the medical center. The hospitals can send your outstanding bills to collection agencies, but many of them are willing to negotiate with you in good faith to set up a payment plan that you can afford. I don't know what your experience has been, but I had extensive discussions with Fred Hutch, UW Medicine billing, and their policy is to not send anybody to collections as a whole if there's a good faith effort by the patient to actually just communicate with them. So they literally reach out to the patient 5 to 10 times, being like, we need to talk to you, what's going on, why are all these bills being unaddressed? And if the patient never answers any of these mails, then after a certain period, they might consider, not actually send them to collections, but they might consider doing more dramatic action. But the first step, they really try to reach out to you to figure out what's going on and to figure out a solution with you. There are also nonprofit organizations like the Northwest Justice Project that can help you with negotiations or clarifying your rights. Do not put any of your medical bills on credit cards because the credit card is going to accrue interest, and then that's going to be another issue. So do not put your bills on credit cards. I have some slides here on housing, transportation, and lodging, but in the interest of time, I'm actually just going to, mostly skip through them. These slides will be made available to you, I think, to your email, so you can look at them in your leisure. So here's some stuff about housing, some stuff about transportation and lodging. And I just want to close with, It's never too early or too late to reassess your financial resources and to truly understand your current insurance plan in preparation for a rainier day. When we spoke to these 30 to 40 patients, some of them really know their financial situation and they know about their insurance. Others have very little idea and they are kind of all over the place. I think that the better we can be prepared now, the more you'll be set for the future, depending on where your cancer course takes you. So I think this is very germane to the next talk on financial planning. So I think we can segue into that. This is my email. If you have any comments, anything you would like me to know, anything you want to discuss, I'm happy to be available via email, and I'll also be available for questions shortly. Thank you very much.
Thank you, Dr. Su. We will move on to our next speaker, and then we'll have a Q&A session at the end where we can go over some of the great comments that we're seeing.
So our next speaker is Chris Burkhart, who is a wealth manager for the Cutler, I believe,
Cutler Investment Group.
Investment Group here in Seattle. And she's also here representing, she is a volunteer for the CENTS program, CENTS, which she does pro bono. And I'm just really appreciative of her willingness to come out on a Saturday and talk to us about financial planning. Thank you.
Hi. Thank you. Yeah, so I'm Chris Burkhart, and I was diagnosed with HER2-positive breast cancer in December of 2020. I started treatment the first business day of 2021, a rather aggressive treatment that continued throughout the year. I ended chemo in December of 2020. During that time, I also had a lumpectomy and radiation. Your situation is a little different, you're being metastatic, but I at least can have a better ability to empathize with what you're going through. I understand how you feel, how chemo makes you feel, how your treatments make you feel. I'm also a mother, family. My oldest daughter is here at UW, which I thought would be great. She's so close, I'll see her all the time. Did not happen, is not happening. And my youngest is a senior in high school here in Seattle. And as she mentioned, I'm also a financial advisor with Cutler Investment Group. I work with all kinds of clients. We investment management and also financial planning. And my passion is really financial planning for retirement. Probably the best benefit my clients get are those who are approaching retirement or in retirement. It's a very interesting time. There are so many variables, so many different things going on with their lives. It's I think the most rewarding for me. And as Cutler Investment Group, we report to the Securities and Exchange Commission, and the SEC requires that I provide this disclosure. This is for informational purposes only. I am not providing investment advice, and I am making no guarantees. And I will take that a step further to say that this is also broad, what I consider broad advice. This is my agenda. We only have 15 minutes. Probably not going to hit all these topics. That's okay, because your situation, your financial situation probably doesn't look like this person sitting next to you, just like your treatment does not look like the person sitting next to you. It doesn't, so it doesn't matter. What I want you to come out of this knowing is I have additional resources like Dr. Su. There are people, there are organizations that want to help you. They are here for you. They understand the unbelievable costs of treatment. They also understand that our system is broken, and they are going to do everything they can to give you support. This is a great place to start. It overlaps actually somewhat with Dr. Su's presentation, which is good. So this organization was started by a bankruptcy attorney who saw so many cases come before her, and she thought, this just could have been prevented. And Sense does many different things. The area that I'm in is their financial planning for cancer program. I learned about it through the Seattle Financial Planning Association. They were looking for volunteers shortly after I finished treatment, and that was perfect match for me. So they'll match you with a financial advisor like me, someone who may have some resources or even just kind of help you think outside the box for solutions to challenges that you're facing. And also, as he mentioned, they partner with the Patient Advocate Foundation to match you if you don't already have a social worker or someone to help you navigate the hospitals and the billing issues, and maybe even talking to your doctors. And it sounds like the Hutch has a great resource for that. If you're going somewhere else and you need help, maybe this is a good place to check out. And these are just two. I would say any financial related question that you don't know where to go to, this is your starting point. All right, so I hear from patients and I hear from friends who have cancer, and I've just kind of put together a few things that I hear periodically, but basically, what's keeping you up at night? Often it's, can I pay for my ongoing treatment? Can I continue to work? I'm okay now, I can manage it. Am I going to be able to work for the long run? If I can't, how am I going to keep my house? If I have a family, how am I going to keep the roof over their heads? How am I going to feed them? What is this going to look like? What are, if I can't work, what might that look like? What are my options? What can I do now to get set for that possibility? And, do I have, insurance, as he mentioned, is critical. And, again, what happens if I run out of money? What does that look like? Who can I reach out to? And, you've got very hard choices. Should I be focusing on my kids over my treatment? Just very hard situation. I cannot provide an answer to that, but I may be able to put some numbers behind it and help you make an educated decision. Yeah, so I don't know if any of these have kind of hit home, or if not, that's okay. There are many other financial problems that could keep us up at night. All right, and great presentation on financial toxicity. I forgot to mention the relationship. Since I believe the Hutch, they did this study on financial toxicity, and they reached out to Hutch and started that partnership to help provide resources once they were able to put a name on something that we already kind of felt and know. All right, so where do we get started? So let's just start from the beginning. If I were to give someone who is just starting treatment, if they were to come to me and say, what's the first thing I should do? I would say, get organized, get all of your stuff together, list all of your assets, your investments, and all the details, where is it located? How much is there? Your checking and savings account. If you have a money market, how much is there? What's the interest rate? All of your financial details. This identified cost is a little bit harder because you might not really know. And if you don't know, that's okay. Make a guess. What do you think it's going to look like? Start tracking your expenses. This one is more challenging. There are tools that you can use. And many different ways to do it. You can track it on paper. You can, there are apps available, although, I don't know, the best one went away. There's one, the second best one is called Monarch, but it's a pay for service. But for some people, it's easier because you can just take your phone, scan your bill, and it automatically uploads it. The other resource that I like most at this point, most of the banks, so your checking and savings or your credit card company, they're going to give you a lot of information online, and you can't access it typically on your phone. It's going to be, you're going to need to go to your computer. But for example, I know Bank of America, I can go in and at the end of the month, I know how much I have, how much I spent or overspent or underspent. And then I can take that whole year, average it out and say, did I overspend this year? Did I underspend this year? Kind of where am I? And then if I'm like, okay, yeah, I spent more than I should have, which is kind of typical for me. Okay, what can I cut back on? And that's where my credit card comes in handy because my Fidelity account actually lists all of every single purchase. It automatically categorizes what that purchase is. I can go in and change it. I don't know if all credit card companies do this, but if not, some of those other like Monarch will do this for you. This just, Fidelity does it for free. Yeah, so I can go in, if it's the wrong category, I can change the category and I can go in at the end of the month and say, okay, so this amount I spent, I had to spend this. This was, living expenses, rent, mortgage. And then there's this other chunk, which did I really need that? And if not, that's where I can start cutting back. And then simplify. It is very difficult to track your expenses if you have multiple credit cards, or even what I see a lot with my clients is multiple bank accounts. You need to have one credit card that you use for almost every purchase and one backup card and no more. So many people have, well, I have my Costco card and I have this card and I only use it for travel expenses. And I have this card that I use just for gifts to my family. Yeah, it makes, and I understand the logic behind it, but it makes it really hard to tell where you are. So yeah, make it easier on yourself, keep it simple. And one checking and savings account, and this is personal, if you have a business that does need to be kept separately. But so many people, well, I got a HELOC at BECU and they made me open this account, so I just use it. Yeah, you don't need to. Just keep it clean. This is also the time where you need to be looking at your estate plan. So your will, your durable power of attorney, your financial healthcare power of attorneys. And if you don't have one, it's time. Yeah, it's time to get one. Sorry, I've got to keep my timer. Yeah. I have a lot to say and not enough time to say it. Yeah, and everything I've talked about here, this is what I talk to my clients about. And I know that you're sick, you're tired, you're spent, your energy is spent. This is the last thing you want to do. I can tell you, you're not special. No one else wants to deal with it either. One thought is find a friend. That friend who is always saying, oh, I really want to help. Well, find out, do they mean it? One thing that I did, my bills, there were so many bills. Why aren't they paying for this? This should be covered. So, and my husband's taxed. He's doing everything he can. And so what I did when my mom came to visit, I had a stack and she would dial I'd say, here you go. Here's the first one. Dial the number. This is what I want you to ask. They get on the phone, verify it's me. And then I'm like, okay, you handle it. And she took care of everything. And that was a huge help. So, one less thing that I had to deal with, reach out to your sources. And yeah, so next, further along in your journey, create a budget. Your costs are becoming a little bit clearer. You might be needing to tap into some of your investment accounts. That's a good time to reach out to Sense. We can help, financial advisors can help you which account is best. Because we're going to look at the taxes, any potential fees. If you pull from your IRA and you're under 59 and a half, typically that all comes out as income, which is going to raise your income tax for the year. And typically you can't do, you have a 10% penalty if you're under 59 and a half. However, there are caveats, and many of you in this room probably meet those requirements. And make it further along in your journey, start thinking of kind of what you have very little under control. Kind of think about what you want your future to look like. Start thinking about a financial plan. And that's where we can help. And I've got some other resources that can help you as well. And, or maybe you're to the point where like, yeah, money, what money? I have none. Again, there are resources. reach out, talk to someone. Don't take on the burden yourself. Know that there's a team who's going to do everything they can to help you. And this is another great resource. So the Sense and Family Reach and Northwest Justice Project, which Dr. Sue mentioned, I left flyers out on the table. You can grab those on your way out. It has their information. I forgot to put my information, so I left my card as well. But yeah, this is an organization, their primary focus is providing support for cancer patients. And I've just listed a handful of things here. They do so much more. What I use them for is they have great worksheets for tracking your expenses and just kind of getting you started, tracking your income, your expenses, your assets, everything that I just talked about. They even have a worksheet that'll help you kind of put together your plan. And I just threw together some examples, some ideas for managing debt. And I listed these in particular, not because there is something about all of these that you need to understand well before you take that step. Like that example for the man who did a reverse mortgage. Reverse mortgages, you need to know, it's a pretty dramatic step. You no longer own your home. There are details, if you read the fine print, that it probably doesn't happen often, but you could lose that right. So you need to know what you're getting into and make sure it's the right solution. And all of these listed are the same way. They're either fees or timelines that you need to know about. Oh, one thing I do want to point out, Social Security disability, Family Reach that I just spoke about. That's another thing that they help with. They will help, if you haven't applied, they will help you apply. If you have been rejected, they can put you in contact with an attorney who will only be paid if you receive benefits. So yes, all of these they may be the best solution, but you need to go into them understanding, knowing what you're paying, what the timelines are, what are the potential downfalls. And that's where an advisor can, I can read your whole life policy and tell you, because let me tell you, it's not easy. And to help you determine what you're paying for the privilege of borrowing your own money. And yeah, so Sense is where you get that started. Okay, one other thing I want to mention is also one of the benefits of talking to a financial advisor is we've seen a lot, we've been through a lot. Maybe there's another alternative. Maybe there's something that you haven't even considered. And I had one woman that I talked to, and we were just brainstorming. She did not want to lose her house. She wanted to keep her house. She knew she wouldn't be able to work for a defined period of time. And renting out a room was not going to cover her bills. So we were thinking about reverse mortgages, other things. And just in talking to her, somehow it came up that she had a friend and her friend was willing to have her move in with her. So she rented out her house for that time and had enough income to cover her needs. And then she had the added benefit of her friend also helped take care of her. Not every situation is this rosy, but you wouldn't have known about it had you not explored it. And sometimes having an outside source, especially outside your family, because they are just so, they're going through this with you. Even maybe some of your close friends, just having someone to talk to, maybe that would strike up a new idea. Thank you, because I'm running behind. But yeah, if you have Medicare Plan D before December 7th, you need to contact your company and you need to confirm that the drugs that you are paying for are going to be covered next year. Because unfortunately, the downside of this benefit, which is going to benefit so many people, is that the drug companies are discontinuing a lot of the plans. 25% of the plans are being cut. And if you do not tell that, I'm assuming they're going to notify you, but I wouldn't wait. Go ahead and call. Make sure that your coverage is going to be there this next January. And two, that they are going to cover the cost of treatment. And maybe that's talk to your oncologist. Are there some possible drugs that I might be on next year? And make sure that those are covered. And if your plan is going away, then you'll make sure that your new plan is going to cover the drugs that you need. And yeah, thank you. The only thing is, I listed the timelines in the journey. That was just to make it easy to present. It doesn't matter where you are. If you are struggling, if you have questions, you have a resource, and yeah, use it. Don't take it on alone. Okay, thank you.
Thank you so much. If you wouldn't mind having a seat and we can have Dr. Sue join us for a quick Q&A period, I'll give you my mic.
Thank you so much, Chris and Chris.
That makes it easy. My husband is actually named Chris as well. And I grew up with 3 Chris's in my neighborhood.
Or neighbors.
So I had a comment on the Medicare Part D plan. I'm not 65, but I'm on Social Security disability. So after 2 years, I'll be automatically eligible for Medicare. So that'll be in November of 2025. So just a comment that Medicare Part D is not, it's not just limited to people who are 65 and Medicare eligible. So if there's anybody else who's younger, and you're not on Social Security disability, I agree, please apply. But those Plan D programs are available if you're younger than 65.
Thank you. Yeah.
I have
Yeah.
a question. Have you guys, with us that have cancer that aren't able to work as much as we used to, have you worked with King County or any of the counties in the state of Washington to help people with their property taxes?
I have worked with clients who are able to lower their property taxes. I don't remember what those qualifications are off the top of my head, but yeah, if that's something that you need help with, yeah, call Sense. That's a great that's a great excuse to call a financial advisor. Yeah.
Are the social workers that work through Fred Hutch familiar with financial resources, transportation, helping with housing, like there's Habitat for Humanity for people to help pay for roofs and repairs? And, when you're having cancer, just having like lists of helpers that can help you with those types of expenses that come out that aren't necessarily all just medical. And there's also an online organization called Triage Cancer. And so are social workers a good place to start if you're a cancer patient?
Yeah, I think here at this cancer center, at least my experience with working with the social workers and the patient navigators is that they're generally very knowledgeable. I mean, I can't speak for every single social worker. I don't know where they all are, but I think overall, Fred Hutch maintains a pretty good, resource, and I would definitely start there first. And certainly, I think another thing that I'd like to mention is, you can always start with the social worker, the patient navigator, but then as you, figure out other patients, especially in like advocacy settings like this, where you're interacting with other patients and other survivors, I actually think the crosstalk between patients is very valuable because people share resources with each other. So I think that's another good resource. But I mean, my experience has been very positive with the social workers.
Hi, I was just wondering, are there fees associated with financial planning?
No, if you go through Sense, no, we were all volunteers.
Can you speak to the benefit of Social Security disability other than getting on Medicare within a certain, within 2 years or whatever it is? If you're under 65. If you're under 65, yeah.
No, I am not well versed in the actual
specifics of, yeah, no.
Okay, because I had heard
worked
through
more
my,
to help people
I had
understand.
heard through my support group, something of the nature of you can basically get monthly distributions and it doesn't go against, unlike if you were to start your Social Security early, it's a negative in the future. My understanding is that you can
That is
get,
correct. Yes,
okay,
yes, yes, yes.
so that's
Yes,
correct.
you are not, yes, you're not penalized for
Penalized,
starting it early like you would be if you, Social Security, if you start at 62, you get a reduced benefit, and then 67, depending on your age, is your full retirement age. That's your full benefit. And then after that, you get an 8% bump each year until age 70. So no, Social Security does not impact that, or social, I'm sorry, disability does not impact that.
It's meaning that you can get your distribution and you're not penalized.
Yes.
Okay,
yes.
thank you.
Dr. Lee, do you have questions from the chat?
Yeah, we have some comments of appreciation for both of you, saying it was such a wonderful presentation, such helpful resources. Some members also shared triagecancer.org as a good website that they've had experience with. And also there's an app for tracking financial information on iOS called Empower Personal that someone has found really helpful. And then someone commented that if you apply for Social Security disability insurance, you may qualify for Medicare afterwards.
Yes. Yes, you do.
But sometimes, or I don't know if it's sometimes or always, or it is, but there's a 2-year waiting period.
That may be, yeah.
There may be. Yeah. Okay.
Your wait list, and if you're under 65 and you're metastatic in Washington State, they fast track. All of these providers should know this.
So that was if you're in Washington State and you're metastatic, you can get that process fast tracked.
Medicare, they fast track the.
They fast track the disability.
Yes, but not the Medicare.
But if you're under 65 and you are still working, but you're hoping to get on Medicare at some point, you're kind of in a rock and a hard place because they limit the amount of income you can make. So I don't know how to. Right. 2 years.
Whether you're working or not, those, to your point though, that it writes your earnings and all that, so if you're not.
If you're over
working,
65.
Under.
Or under, sorry, under 65, correct, yes.
But if you had to get benefits, then you're.
Right, so I'm not working, so to your point, you know, my disability is paid out as if it's my full retirement amount. It's my 67 amount. If I live to 67, it's not gonna say disability, it's just gonna switch to retirement, so the amount stays the same.
So metastatic breast cancer is an automatic yes for Social Security disability. Yes.
So you get fast tracked because there is no appeal process or something. You have metastatic cancer. It's an automatic category for yes on Social Security disability. So that's the fast track. You get it very, very quickly. Once you're on Medicare, Social Security disability, in 2 years, you will qualify for Medicare health insurance. The 2-year gap of insurance, that's the hard part. Whether you COBRA, whether you get Medi-Cal, whether you know, whatever, but there's a 2-year gap of health insurance that you need to cover. So, and you get your Part D when you qualify for Medicare. And you have to buy that.
My husband and I were small business owners, and you know, I'm on SSDI, and he pays, you know, top dollar for insurance for my son and him, and then, you know, my accumulative is almost about $500 a month. So, you know, we're paying well over like $1,200 just for the luxury of having healthcare. Yeah. Anyways, prior to my diagnosis, I belonged to the paradigm of medicine that was homeopathic, naturopathic medicine. And I was so excited to finally get on Medicare after 2 years of hell of not being able to really, provide fully for my family, living in communities so we could afford living. And then when I got Medicare, I no longer could see doctors that I saw since I was 18 years old. Since I became an adult, I no longer could see homeopathic, naturopathic doctors with my SSDI Medicare. Well, I don't know how to navigate modern medicine, doctors, and paradigms. And I am neurodivergent. And so it's been really challenging to get the care. Like when friends are like, oh, I'm going to get body care done. I got to go to acupuncturist. Yeah, I'm going to go to get a massage. But I don't get any of that. And so that's very frustrating for me. So I feel very abandoned, like I don't get representation for a program I pay into and participate with. So are there any financial, like healthcare savings accounts or something for people like me, where it's like even our government matches, since they're leaving me behind in my paradigm of medicine and I'm just supposed to conform or something? Like, is there any financial help out there for people who also want the integrative, like a truly an integrative approach, not just, integrative through Fred Hutch, because it doesn't serve me, because again, I'm under 65 and on Medicare. So are there any programs like that? Are there insurance companies out there designed for people who want integrative? Anyone?
So I have not had that question before.
Yeah.
That is, yeah. Go through Sense, see if you can contact me, and we'll research. I'll research the answer and see if there is. Yeah, because I don't know of anything off the top of my head. So.
Okay, thank you.
Thank you both so much. Do you have other closing thoughts? I'm sorry that this is obviously a very active issue for everyone, but I do want us to be able to have a quick break. We're running a little bit behind, but I do want to invite Chris and Chris to share any closing thoughts that they might have.
Yeah, no, I mean, for me, just, if you have anything you want to discuss with me, anything you want clarification on, I'm happy to be reached on my email. I hope the organizers can make my slides available to you. Hopefully they'll be helpful.
Yeah, and yes, feel free to reach out as well. Again, I left some resources on the table, give you their contact information.
Great. So we will take a break. Minute of pledge that we want to have for you all. So thank you for coming back in and getting settled. Reminder that we have our narrative interview booths. And Katrina, if you are out there, it's your turn. We also have a new opening if someone is interested in participating in the narrative interview at 11:20. At 11:20, there's also an opening. So if you are interested in that, you can come over here to the sign and let us know. And our next speaker is Dr. Susanne Weber, who is a psychiatrist here at Fred Hutch and also works as a clinical assistant professor in the Department of Psychiatry and Behavioral Sciences at University of Washington. And she's going to speak about changing relationships and coping with anxiety. So Dr. Weber, thank you so much for joining us today.
Thank you so much, Ben. Great. All right. And I want to be mindful of the time, and we've got a lot to cover. Everyone here is trying to fit a lot into these minutes. So here I go. Timer started, 20 minutes. And so with our talk today, just thinking about uncertainty, which certainly there is a lot of uncertainty if you're dealing with metastatic breast cancer, living with cancer, and how that impacts relationships in our lives day to day. So thinking about first about awareness and acceptance when we're thinking about cancer diagnosis and our emotional reactions. And then I want to touch on coping and living in the moment, and then our changing roles and patterns.
And so when I'm meeting with someone and we're first thinking about the roles of worry and anxiety in their day-to-day lives, we think about, where are you sitting on a spectrum? How are you noticing those thoughts about the future, thoughts about worry? Some folks want to shut it out. They want to avoid it. They don't want to think about it. And in an extreme way, that could be unhelpful. On the other end of the spectrum, if you find that you're always thinking about your cancer diagnosis, treatment, the uncertainty of the future, that can also be really overwhelming. And people can feel like they're having a physical reaction. They're getting into panic. And so this isn't something where you live as a singular dot on the spectrum day in and day out. This can change within a day, that you can be moving through your day and feeling fine, not thinking about things, but something could hit you, something could remind you about living with breast cancer, and it could be really difficult. And all of those worries about the future could really hit hard. And then as I'm talking with someone about how are they experiencing worries while they're living with breast cancer, one of the things I like to ask people is, are these thoughts true? When we're projecting and living into the future, imagining what could happen, is that future something that is certain, that we know, or is it more unknowns? And to some degree, I want to thank Dr. Vinayak for her talk, because she kind of gave my talk already, which is great. And you'll notice at the beginning of her talk, she had a lot of questions and question marks on those first slides. What's going to happen with my life? What will treatment be like? How long could I live? And a lot of those questions that came up for her and were so intense, as we're getting to the end of her talk, she said, some of those I just can't know. And some of these things I'll just have to sit with and live with. Another thing that I like to think about with worries about the future is, are these worries unhelpful thoughts? Or are these worries helpful in some ways? Because I don't want to label anxiety as being something that's purely good or bad. Sometimes it's good to worry. You should be worried if you're giving a talk, and you need to prepare for that talk, and you know what you're going to say. If you're throwing a huge party, you want to make sure, how many people are coming? Do I have the food I need? Do I have everything prepared so that we're all going to have a great time? So I think there's lots of ways where anxiety can be useful, worries can be useful, especially when we're thinking about our sphere of control. So what are the factors in day-to-day life that I can change that are really going to impact the thing that I'm worrying about? And I want to validate that living with cancer, there's a lot of inherent worry. It's absolutely valid. It's absolutely normal. It would be strange if you were coming in and saying, I've got no cares in the world. Because when I think about the worries that people come to me with, that come up for them day to day, they're truly a reflection of the things that are important to them. So they're worried about finances. They're worried about their loved ones. They're worried about their future because they want to be there with the people who are important to them. And they want to do those things that are meaningful. So I don't want us to think of anxiety as something that's bad that we need to squash, but it's something that we should build some awareness around so we can see, how is it impacting how I feel day to day? And is it something that could actually be beneficial, that I could use in a positive way? And so places where people might have a little worry that can be a kick in the butt is for making healthy diet changes, getting in a little bit more exercise. Factors that you can control that will make a difference. And so when does worry get in the way? When it's not helpful, when we're worried about things that maybe we don't have control over, which can be hard. When the worries get to a point where they're getting in the way of the things that we'd want to be doing, that we're so worried about getting out of the house, how are we going to do, that we find we're not seeing the people or the friends who are important to us. Or if those worries really feel overwhelming, they feel like they're just too much. So now that you've got some awareness in terms of worry and anxiety day to day, how do you want to react to that? Especially when anxiety feels overwhelming, the first place that I think about going is grounding myself. So grounding yourself in the present moment, pulling yourself back from that future of uncertainty where the brain wants to invent stories about what could happen. The brain wants to problem solve. How are we going to fix this? Come back from the future into the now, into the present, and ground into your own body. And so if you'll permit me, we will do a brief grounding exercise, which is a favorite of mine. Mindfully doing a 5, 4, 3, 2, 1 grounding exercise. And so to start it off, if you're feeling comfortable, you can close your eyes or you can leave your eyes open. And just take a couple of deep breaths in and out. And in, feeling the air flow in and out again. And just allow yourself to be right here, letting the chair support you. And for number 5, for our grounding in the moment exercise, we're going to think about our sense of sight. So now's the time to open your eyes and look at what your eyes just naturally fall on. And I want you to find 5 things to observe around you in the room. And you can put a label on those things. Maybe you see a chair. Maybe you see somebody's hair. Think about the color, texture. Just really allow yourself to fully observe the things that you're seeing right now. And then take a moment to close your eyes again and really focus on hearing. And notice, are there 4 things around you that you can hear? I can hear the ventilation system. Think about, is it soft or loud? Is it staccato, smooth? You can hear my voice. Are there people murmuring? Feet shuffling? And now shift to thinking about 3 things that you can feel, that you can touch with your hands. And you may be able to feel your own skin and the warmth of your body and the qualities of the clothes that you're wearing. The chair, is it hard? Is it smooth? Is it soft? And then for number 2, we have 2 things that you can smell. That might be tricky. If you're at home, you might be able to smell food. If you're outside, you could smell the rain or the leaves. If you're in a clinic, you might be able to smell all of the wonderful cleaning supplies we use to keep it so clean and antiseptic. And then the last one is taste. And you can open your eyes, because the taste one's hard. If you just had a snack, you might be able to pull it off. But sometimes if people find that a grounding exercise that pulls them into this present moment is really helpful, they might carry something like a piece of gum or a hard candy with them so they can pop that in and just really allow themselves to sink into that. And so once you've found that you're a little more grounded, you're a little more into the present, then the next thing we can think about is, how do we want to cope? How do we want to shift things? And so here are some thoughts about how to cope in this circle. So the distraction is on top with the big action. What do you want to do? And I think that's what Dr. Vinayak was really focusing on in her talk as well. What's important? You're shifted, you're here in the moment. Is it important to do something? Is there something on your to-do list? Do you want to feel productive and get just one little thing done? Is it good to just enjoy some self-compassion and say, I'm going to take care of myself in this moment. I'm going to take a break. I need a break. I need a nap. I'm going to get something to drink. I just realized I'm hungry. I haven't had the time to just pull back and realize what my body needs. I think on the bottom of the circle, acceptance can be great, because there are times where we can't change something. Maybe there isn't a good next action to take, and to just radically accept that this is hard right now. This is a hard moment. It's okay to have hard moments. It's okay to feel these emotions, because they don't last forever. The emotion will come and the emotion will go. And so just allowing yourself to sit there with that feeling can be really helpful. And then on the left side, connection. Sometimes it's good to connect with that friend. It's just a friend for fun. You need a distraction. They love to talk about themselves. Let them do it. and sometimes you need to connect with someone who really wants to listen. And sometimes that's useful to have that person and to connect with them as well. And so having those people in your life can be huge. I wanted to give a moment to talk about the scanxiety. And so, and then this was again something that Dr. Vinayak talked about. This feeling that you're living from appointment to appointment in terms of the restaging and where are things out with progression, where are things out with my treatment, the lab work, the imaging. And it's extremely common. It's extremely normal. I don't know that I've talked to anyone who says, I don't have this. And it starts hours to weeks before the appointment. It starts to build. And that worst case scenario thinking gets started. And you're all of a sudden you're in the future and you're trying to problem solve, well, what am I going to do? And it takes you out of the present. It takes you out of what you can do now that would be important to you now, what would be enjoyable to you now. And sometimes with that level of anxiety, people can get into that fight or flight or freeze. And that is a very normal reaction that is useful. If a bear is chasing you, you want that adrenaline to kick in so you can hide, or you can fight the bear, or you can run. It's not super helpful if you have a scan coming up in a week to have all your muscles flooded with blood ready to run. So that's where we think about coping ahead. So if you've got a good day-to-day routine, wonderful, keep it up. How are you doing in the morning? How do you get your day started? How are you at regular meals? Is there a way to have some movement in the day? So keep some of that regular routine going, even if things feel difficult and overwhelming, if you can. Reframing difficult thoughts. And so some of this is kind of just validating where you're at in a lot of ways. So you're having a thought, could something have changed on the scans that's going to be scary? And you can say, perhaps, I don't know, check the facts. What I do know is this is where my treatment was before, this is where my cancer was before, and kind of ground yourself there. Or if you're thinking about those worst case scenarios, is it true? Is it helpful? What's a thought that's more helpful for me? Well, if things have progressed and we're looking at more difficulties, the people around me have really rallied and helped me out. And I know I've got that support. I know my options. I've talked with my team. I trust my team. So leaning into that. And then allowing those difficult thoughts to come and go. So pushing away the difficult thoughts doesn't work so hot. The idea is don't think of a pink elephant. The second you're trying not to think about it, you're thinking about it. So just let those thoughts come and go, just like the emotions, the feelings will naturally. And leverage that rest and digest. So the flip side of the coin for the fight or flight, rest and digest. That's calming down the body, using mindfulness, breathing, body scans. And then decide ahead of time, how do you want to look at the results when they come in before your appointment with oncology? Because some people want to know right away, and some people don't. And sometimes you just got to decide what's going to be best for you in that waiting period. And so acknowledging that living with breast cancer impacts and changes things. It impacts how you feel physically, mentally, emotional. It impacts what you're able to do with your day. It impacts how you think about yourself, kind of your roles in your family, roles in working, and how you think about other people in the world around you. And so, of course, it's going to impact the interactions that you have with other people, shifting roles, that sometimes you're the caregiver and you're helping out the people around you. And historically, a lot of adults have been caregivers for other people, kids, spouses, and suddenly needing help from others, shifting from being someone who works to someone who may be retired or on medical leave. The roles for parent and child can feel like they flip back and forth a little bit, depending on the situation. And acknowledging what Dr. Vinayak, I just met her name, Vinayak, thank you so much, was saying about the people in your life who seem to disappear, whether you get cancer ghosted, people who are close and then they feel like strangers, and acknowledging the people who feel like they've been strangers and then they come together during tough times, and the shifting relationship patterns that can come up because suddenly you're not able to do the things in a day that you usually did, and your reactions may not be the same. Like she was saying, sometimes I'm having a hard time and I can't have that same loving, present reaction for my spouse. I just need to take a break. I'm angry, I'm having a hard time, I'm breathing. And so instead of being stressed out with our loved ones, why are they like that? What are they doing? In times of stress, we'll notice that the differences between people can feel more pronounced, bigger. So maybe you have a roommate, maybe you have a family member that you live with, and on the cleanliness scale of 1 to 10, you're 6, and they're 4. That's not a big difference. It feels like a big difference when the person who's a 6 isn't able to keep up the house they want to in the same way, and they're leaning on number 4 to do it. Then you have the clean freak and you have the slob. And so I think that that's a dynamic that can come up for a lot of people, that those differences feel a lot bigger when we're under stress. And so I think here acceptance is really key, because we can't change other people as much as we want to. And I wish I had that talk, how to change the people you live with so they do exactly what you want them to do. I don't have that talk. It's easier to accept that the differences have always been there, and to accept the parts that work, and really to focus on the things that you love about the people in your life, and to reinforce the things that are great. So maybe someone's not going to vacuum as much as you wanted them to, but maybe they make a mean casserole. And so I think that looking at the positives is helpful, and then defining your own limits, and of course, finding shared goals. So I think a lot of the overarching shared goals I talk about with people are, how do we live a good life with cancer? That we're still living, that it's not driving the bus. And I think that's something that family members, friends can come together on. So it's okay to set boundaries. That was another big one. Boundaries are about your limits. So again, you can't make anyone do anything else, but you can let people know what works for you and be honest about what you can do. Boundaries are kind. They set expectations so that people don't expect that you're still going to act the same way that you did in the past, that you're able to do the same ways in the past. Because if they have those old expectations, they're going to be disappointed and hurt. But if you let them know what's changed and what you can do, that can be a really loving thing to provide them. And so some examples for boundaries, it's up to you to decide who knows about your diagnosis, where your cancer is at, what kind of treatment you're getting. It's up to you who you discuss your health with. And you can come up with really graceful ways to tell people, no thanks, I don't want to talk about my cancer. I think about it enough. What's going on with you? I'd love to hear, how are your kids? Again, people love to talk about themselves. And it's up to you what you spend your precious time and energy on. So there may be things that you used to spend time and energy on that you don't anymore, and that's okay. And then letting other people know boundaries around social distancing and infection risk, especially as we're in flu season, COVID season, things like that. And those are all important things to talk about, and they're all good things, loving things for your safety and others. This is one little pearl I wanted to give you. If I'm 1 minute left, let's do it. Okay, the Dear Man. So this is, if you've got a big ask, a big concern with someone in your life, and you want to let them know what you need, this is a really great way to do it. It's called Dear Man, and it was developed by Marshall Linehan, who is an amazing psychotherapist here at the University of Washington. You describe the problem. So describing it, anybody got a problem? They need somebody to fix a thing, do something different in their lives. Yes. Yes, describe the situation. So you've been coming to all of my appointments with me since I've gotten this diagnosis, and you've been a big support for me. And cancer is now a chronic condition for me. I'm going to have a lot of appointments, and how that makes me feel. Dang it, out of time. We'll keep going. So, and sometimes when you're at the appointments, it can feel like a lot, like the appointment is already a lot for me, and that I feel guilty asking you not to be there, but this is how I'm feeling about it. So my hope is that you can take a break and not come to all of the appointments with me, because then I'll feel a little less overwhelmed by the appointments. That's the reinforcing. I'm going to feel less overwhelmed. And what that means is that when I come back from the appointments, we're going to be able to have more pleasant time together and catch up. And you're really mindful about how you're making this request. You're describing the situation at hand. You're expressing how it makes you feel. You're asking or asserting for what you want. And you're reinforcing, how does this work out well for both of us? And you're not dragging in the kitchen sink. You're not saying, you know how you used to smother me when I was a kid and come to all of my games and scream at me. So you're not bringing in all the other complaints. You're just saying, this is the one issue where I think a change would help both of us. Appear confident in making this request and have some room to negotiate. So you might say, I'd prefer to come to all of my visits alone. But maybe there are some visits where if you really want to come, you can come to a few. So be prepared for that. And so that's one to put in the back pocket. And then of course, well, like you're already connected with this amazing breast cancer community and the other people living with metastatic breast cancer. Just a few ideas here at Mermaid's Angels to connect one-to-one with a support person. CancerConnect.com also has some resources here at FACOG. We have support groups. Susan G. Komen, Cancer Lifeline is also great in terms of support groups. But these connections here are amazing. And I can stand up here and talk about my patient experiences, but at the end of the day, I'm not living it. And the people who really get it sometimes are really valuable resources to have in your life. All right, thank you so much.
Thank you so much. If we can hold questions for just a moment, Suzanne, if you wouldn't mind having a seat in a moment when we can hold a Q&A. I have the pleasure of introducing Dr. Linda Mihalov, who is a colleague that I send a lot of referrals to. Some of you in this room may have seen her. And so I'm very pleased to introduce her talk.
Thank you. Can everyone hear me okay? Great. I really appreciate the opportunity to talk to you today. We're going to get pretty biological now on a different part of the body that you might not have talked about yet. And, you know, I'm a gynecologist. I've been doing this for 40 years. And I love to talk about the vagina because a lot of people don't talk about it. And it's really an important part of our bodies. And we need to honor that. And just because you're a certain age doesn't mean that you shouldn't care about the health of your vagina. And, well, let me say first, I want to acknowledge that not every, I'm going to use the word women a lot because that is the way the literature is written and that's the way, you know, the world is designed. But I want to recognize that not everybody who has a vagina identifies as a woman and not everybody is a woman who has a vagina. So that being said, see how we advance here. So the World Health Organization agrees with me that sexual function is an important part of being a healthy human being. And it's not merely the absence of, so basically it's important for all of us and requires a positive, respectful approach to sexuality and relationships, possibility of having pleasurable and safe sexual experiences. And sexual health doesn't get old. So regardless of what you see in media, it's not all about young, nubile people having sex. People of all ages are sexually active and you don't know until you talk to somebody about it. And if nobody's talking to you about it in your medical care, then go see a gynecologist because we will definitely talk to you about it. So our objectives today are to, sorry, there we go. To talk about vaginal anatomy and physiology and the importance of estrogen, review the agents for enhancing vaginal health when estrogen levels are low, and review the benefits and risks of vaginal estrogen therapy. So reviewing the, see my pointer? Let's see. Is that showing up? No. How do I get the pointer to show up? Is it the which button? There you go. Thank you. It didn't occur to me. Thank you. So we're, you know, when you go for a pap smear, we're looking at just this little part right here. Pap smear only assesses the health of the cervix, doesn't say anything about the uterus, the vagina, the vulva. And what I want to talk about today is focusing on the vagina. And just because you don't need a pap smear, if your doctor has told you you had a hysterectomy, you don't need a pap smear ever again, just because you're over 65 and your doctor says you don't need pap smears anymore, doesn't mean that you shouldn't have someone pay attention to this part of your body, which you still have. So the vast majority of women still have a vagina and a vulva, this part out here. I am not pressing this. Let me do it that way. Okay, so when we talk about the vagina, the vagina is of course the inside part, the canal to the cervix and the uterus. This part out here is technically called the vulva. And each part of this has its own name, which I'm not going to go through. But one thing I would like you to know is that this part of the vulva, the outer part, comes embryologically when we are developing in the womb, comes from a different kind of tissue than the part that lines the vagina. And those different parts of the body can have different sensitivities to estrogen, your body's own estrogen or estrogen that you use later on. And this is kind of what happens. I would guess that most people who have dealt with breast cancer have estrogen receptor positive cancer and are then treated with something that deprives them of their own estrogen, or they're already postmenopausal and their estrogen levels are low. So if you can see here that the vaginal walls in the before menopause state have little folds in them, that's what allows the vagina to stretch, to allow intercourse to happen and to allow baby to come out, right? So there's little pleats in the wall. what happens after menopause when estrogen levels are low or absent is that this wall gets very smooth. You can see the difference in the blood flow here compared to here, it's very thin. This is a little bit more of a close-up. You can see those folds there. So what happens, and the vagina produces its own moisture. It doesn't just, it's not coming from the uterus. So you still produce moisture if you have estrogen in your system, even after the uterus is gone, if you've had hysterectomy. So the lubrication comes from out of the walls of the vagina. And after menopause, when the estrogen is low, that wall gets smoother, it gets drier, there's not as much lubrication, and the vulva also gets smaller. The labia just kind of disappear. Now, graphic picture coming up. It's amazingly hard to find good photos of vaginas on the internet that are useful for this. It's hard to believe. You can find a lot of other body parts, but you cannot find good clinical photos. So this is my attempt. So this is a premenopausal woman's vagina. You can see those folds in the wall. You can see that secretion, which is perfectly normal. Ignore this, that's the cervix, the villus is not. And then this is a postmenopausal woman's vagina. You can see it's a lot smoother. The walls are kind of red, obviously not the same person. And there is some discharge there, but not as much in the previous one. Again, just to drive the point home, this is kind of what the vaginal wall looks like with estrogen and without it. Now, let's move on to what happens with sex. This is the development of the sexual response. If you're my age, you remember the Masters and Johnson, who identified this arousal stage, a little bit of a plateau, then an orgasm, and if you're lucky, a few in a row, but mostly resolution, and then you could start up again. Helen Singer Kaplan in the 70s addressed a little bit more accurately what happens with women and also talked about desire. This model, the Masters and Johnson model, didn't talk about desire. It was just presuming that everything starts with arousal. But you have to get yourself there, right? And more so for women than for men. And this is maybe the most important slide in the whole presentation. And this is Rosemary Basson from the University of British Columbia developed this model that is really much more accurate, I think, and reflective of what goes on in women, which is that the arousal can come after there is starting over here often with this emotional intimacy. So getting into, if you're a sexually neutral woman, as she describes, if you get into a sexual situation, an intimate situation where you want to be with your partner, you want to be sexually intimate, but it wasn't like you thought about it all day long, where your brain was saying, wow, I'm really horny right now. It's just something that you want to do with this person that you care about and that you've been intimate with maybe for many years. But getting into that situation, then once you start to be intimate with one another, then the arousal will come. And that will develop into, actually getting into the rest of that cycle. So if you have something that wants you to it can allow you to seek out sexual stimuli. But you don't necessarily expect that you're always going to start from this spontaneous desire situation. So I think that's an important thing to know, that just getting into the situation and allowing yourself to be intimate may allow you to get into an arousal state that you didn't think that you were ever going to have. Because I hear this from many, many patients who say, I don't care if I ever have sex again, but I have this partner that I love and I want to be with, what is it ever going to come back? And the other thing, the reason I started with the vagina is that none of this is very useful if sex is going to turn out to be painful. So we have to do everything we can to try to get the vagina healthy so that the sex that you do have is comfortable. And if you've been in this low estrogen state for a long time, it may take a while to get back to a place where it's comfortable, which means that you might not be able, even if you come to me and I start you with the endorsement of your oncologist on vaginal estrogen, you're not necessarily going to be able to go, home and say, wow, I got this treatment. I've just started on it. Now we can have sex again. It may take a little while to get to a point where it's comfortable. And that may mean that you get into a situation where you're basically having foreplay and you're not expecting that you're going to have full-on intercourse at the very beginning. But if you have a partner that you are comfortable with and you can discuss these things and work on it, you can get back to where you were before. It may never be exactly the same, but that's sort of true of aging, isn't it? Anyway, so the condition that I'm talking about used to be called atrophic vaginitis, The current term is genitourinary syndrome of menopause. And this is what happens when estrogen levels are low after natural or induced menopause. It also affects the bladder and the urethra. So many women who have this condition will have urinary frequency. Gosh, I have to get up so many times during the night. I feel like I can't quite make it to the bathroom when I put my keys in the door to get home. So all of this is part of this syndrome. The estrogen is the main hormone that promotes healthy tissue. So the absence of the estrogen can cause these symptoms. These symptoms often develop gradually with natural menopause and sometimes long after the hot flashes have gone away, but they may develop more rapidly in somebody who has an abrupt drop in estrogen level, like their ovaries are removed surgically, or if they go on Leuprolide, which probably, some of you have taken, or following chemotherapy that damages the ovaries, which many of the common chemotherapies do. It isn't always permanent in people who have only experienced chemotherapy, but it typically lasts for quite a while. And these are the symptoms. So irritation of the outside of the vagina, inadequate lubrication, as we talked, burning. Sometimes people feel like, oh, I tried to have sex and there's an obstruction there. Something's wrong because he can't even get in. And that's because of that absence of stretching. It's not just the lubricant, it's the absence of the stretch. So the scope of the problem is that 40 to 60% of postmenopausal women have this, but only a few are treated, which is a travesty in my book. And many people don't realize that these symptoms get worse as you get older for many people. And many people don't realize that there's even a treatment for it. And good sex is adding significantly to the value of a relationship, but when it's bad, or it's absent, it diminishes the relationship by a lot. And big part of the problem is that nobody's asking you about your vagina, I'm guessing. So that's why you should talk to a gynecologist. There are a lot of women with breast cancer in the world, as I'm sure you all know. I don't have to tell you that. Many of them are young. And if you add in women who are at risk for breast cancer, then there's a lot of people who are suffering from this condition and are being undertreated. The first mainstay of treatment is to add lubrication, add moisture. So two aspects of this. One is a moisturizer, and that is something you would use on a regular basis, just like you moisturize your skin. It so happens, well, we'll talk about that in a minute. And lubricants are what you use when you're putting something in the vagina. Your fingers, somebody else's fingers, a toy, or a partner's penis. And so lubricant is important, and it's not a failing. It's not to say, we're something wrong with us that we have to use lubricant. It's normal. The standard recommendation is to avoid use of petroleum-based products, but Jen Gunter, who's a very smart gynecologist that you should all follow if you're interested in this sort of thing, says petroleum jelly is a natural product and it's okay. Douching is not a good idea. That gynecologists don't recommend douching for anything. And continuing to be sexually active can help to keep things opened up. It's a little harder to get back if you haven't had sex for 20 years. But obviously you're only doing it if you want to. This is an example of some of the lubricants and the moisturizers. There are many on the market. I have a couple of samples that you can pick up some at the end. I'll put them out on the table. Uber Lube happens to be one that is popular with gynecologists. Maybe it's because they advertise at our conferences, but it's a good lubricant. Astroglide is one that's been around for years, and Astroglide, all of the lubricants come in water-based and silicone-based. And for some reason, people have an idea that water-based is healthier, but I think the silicone lubricants work a lot better. They're a lot slipperier. The oil-based, you can use oil. You can use coconut oil actually as a moisturizer. That's probably the first thing we recommend because it's so easy to come by. All of these lubricants, some of them you can buy. Astroglide, I think you can probably buy in Bartell's if you can find a Bartell's anymore. Or those kinds of stores. Some of the Uber Lube, usually you buy online. Amazon carries, you know, a huge variety of these products. Or you can go to an adult store where you can actually test them. They have testers in there. You can see what you like. The coconut oil, some people recommend using single origin organic. I'm not sure that's necessary, but if that's what you like, you know, even Trader Joe's sells it in individual packets like this. Handy for travel. So the moisturizer you want to use on a regular basis, and you can do that even if you're not having sex or wanting to have sex, or if you don't have a partner. You can use a moisturizer regularly so that you can feel more comfortable, and especially if you're having those bladder issues, the moisturizer can help with that too. This is a study on using a hyaluronic acid-based moisturizer. There's several products on the market. There's one called Hyalodyne that's been around for a long time. That comes in a gel or a suppository that you put in the vagina. And this one, they said in this study that 5 times a week appeared to be the most effective. There's also a product called Reverie. Reverie, Bonafide people advertise a lot on social media, so you've probably seen that product, but there are many others. So this is the same hyaluronic acid that's in the facial things. So vaginal estrogen is really the most effective treatment. And some of these slides are from the North American Menopause Society position statements on various aspects of menopause. You can go to the website called menopause.org, which has a lot of consumer information. And basically the bottom line of the position statement on genitourinary syndrome of menopause is that vaginal estrogen provides sufficient estrogen levels to relieve symptoms of GSM with minimal absorption. And if women only have GSM, then vaginal estrogen is recommended over taking a pill or using a patch of estrogen. And sometimes women, as I showed you, there's a difference in the formation of the different parts of the vulva vagina. And sometimes even women that are taking a patch or a pill also need some estrogen on the outside of their vagina. And we have several different formats that I'll talk to you about. And vaginal estrogen has been shown to reduce the incidence of recurrent urinary tract infections, which is a very common problem in older women. So this is sort of the story of vaginal estrogen. Premarin was initially approved in 1946, which is why it's such a travesty that it's still so expensive, and many insurances don't want to cover it because this drug has been around longer than 90% of the public. Later came estradiol cream, which is actually the hormone that our bodies make, so it's a little more natural. And then in 1996, 50 years later, we got the ring, which, and that's a ring about this big, a flexible ring that you put in the vagina, you leave there for 3 months. It produces a very low level of estrogen that works in the vagina, doesn't go anywhere else in your body to any degree. It doesn't do anything for any other menopausal symptoms. And then you take it out after 3 months and throw it away, put in a new one. And then later in the 2000s, we got the vaginal tablets. So this original product was called Vagifem. It's now available in a generic. And this comes in a little, I'll show you in the next page, next slide. This one comes packaged in an applicator with a tiny pill on the end. You put the applicator in like a skinny little tampon, press the button on the end like this, and the tablet goes, and it's formulated in such a way that it sticks very well to the vaginal lining, so it isn't going to fall out. And that one usually, and then this is the ring, and these are the most recent product, which is called Imvexy. which is an insert. So that is packaged in a little blister pack, and you just take it out and push it in with your finger without the applicator. And typically the long-term maintenance use of the tablets is twice a week for maintenance after using it daily for 2 weeks. Your oncologist might not want you to do the daily loading dose, but you may start with twice a week. It takes a little bit longer to take effect. The cream is used in various doses, and we tend to favor for people who really need the low measured dose to use either the tablet or the ring. But there are many women who, again, because of the difference in the tissues and the receptivity to estrogen, many women also need a little bit, just like a pea-sized amount of estrogen cream around the opening, just to work on that tissue, because it's a little different than the inside of the vagina. And the issues, as I said, many insurance companies, many of the Medicare prescription plans will only cover one of these products, as if they're all the same and as if the patients are all the same. It's baffling. So that is something we have, let me come back to that for a minute. There's another product called Intrarosa or Prasterone, which is it's not an estrogen. It's a sort of an androgen or a testosterone type product that works in the same way as estrogen in the vagina. And this is often, many experts recommend this as the first choice for women who are on aromatase inhibitors. This is used every day, and it can be a little bit more messy, people say. This is what you load the suppository on the end of the applicator and then put that in. The most common side effect tends to be that discharge with it. And again, it doesn't really change anything in the blood levels. It doesn't have a black box warning on it like the estrogen does. And there are studies on the way in breast cancer survivors specifically. We kind of talked about that. All the products have similar efficacy. There isn't one that's necessarily any better than another in terms of how well it works. It depends on the particular person. Am I running out of time? Okay, I can wrap it up pretty quickly here. Big studies comparing them about the same. There is, I want to get to this slide. So the Women's Health Initiative, which was a huge study, of which Fred Hutch was one of the key participants, involved 16,000 women after menopause, and a more recent study one of the studies from that trial looked at the risk of breast cancer and other outcomes in women who used only vaginal estrogen, and there was no difference in the vaginal estrogen versus non-estrogen users in the risk of breast cancer, stroke, colorectal cancer. So there was so basically it's not really getting systemically absorbed. This is regarding the labeling, which I won't talk more about. These are the prescription therapies that are available. There's an oral drug that does the same thing, but it's not recommended for breast cancer survivors because it wasn't tested. So other things that can be useful are using vaginal dilators, and sometimes that's necessary. I have some I can show and tell in the break. I mean, in the Q&A. Pelvic floor physical therapy can be very useful to help you learn how to relax. If this painful situation has been going on a long time, your body has a natural reaction. Lidocaine, which is a local anesthetic applied to the vulva, can be useful. We don't recommend using lasers or other energy devices to treat the vagina. And there are a number of studies underway. I'll just run through this. So there's no scientific evidence for use it or lose it, meaning it isn't true that if you haven't had sex for a while, you won't be able to ever again. That's not true. And these are the things that we don't recommend: vaginal or vulvar testosterone, any other bioidentical, supposedly. These are the references. Are the participants having access to the slides? Okay, yeah, so you'll have access to all of this. So that's my last slide. Thank you very much.
Thank you so much. Can we get? That was me. Yeah, please. Did the computer survive? Yeah. Oh, good.
Great, thank you. So I wanted to lead off with a few statements and then first question, and then we'll open it up. But one question that you may have is, okay, I see a lot of information about vaginal estrogen therapy, but what about me? I already have breast cancer. I have ER positive breast cancer. Is this going to make my cancer worse? Is this safe? And it is safe.
Thank you for saying that. Yes. We have a lot of breast oncologists in our organization, and it has been my experience that there's only one who is slightly leery about their breast cancer patients using vaginal estrogen. And it is always a good idea to check with your oncologist about this. But the vast majority of our doctors have been comfortable with me prescribing a lot of vaginal estrogen in these buildings. Thank you for saying that.
Great. Yeah. So really what you can see is a lot of this information about vaginal care really can apply to many people in here. And so we hope that you feel empowered that, hey, this is another part of my body that I can take care of that can lead to some nice benefits. And on that note, I did want to make a comment about sort of the relationship with your partner. During this time, now that you have metastatic breast cancer, and there may be a number of things that you are experiencing, or maybe that some of your friends in your support groups are experiencing, such as medication side effects, hormonal changes, new pain, fatigue, shortness of breath. There are other physical manifestations that can affect you and can affect your relationship. There may be physical changes from the treatments that you've had in the past or the disease itself, and we wanted to acknowledge that. You're not alone. This is something that is a challenge, oftentimes with partners, and you may feel less desirable. And on the flip side of this, we wanted to bring to light that it's a two-way experience. The partner is also going through some changes. They may still have the sort of same sexual desire, but if one side still has it and the other side, due to a number of factors may not, now there's a discrepancy in how to reconcile that. So I think I'll sort of ask this question to Dr. Weber and Dr. Mihalov. How can we work as a team, sort of, as a partner pair? Any practical advice for confronting some of these aforementioned issues? Feasible or practical tips?
Well, I would say recognizing that sexual response cycle, I think, is really important. And I think continuing for the partner to continue to reassure the partner who's dealing with cancer that they are still desirable and that they are a whole person and their whole body is desirable. And it doesn't matter that they may be, missing a part or a couple of parts, but they still are desirable. And also, what I was talking about going slowly and not necessarily expecting that full-on intercourse is going to happen every single time. And recognizing that the partner is still, still has human needs, even though she may be spending all of her, what seems like all of her time thinking about her cancer. She's still living, she's still a human being, and she still has those same human needs. The other thing is that a lot of patients tell me I'm ready to have sex, but my husband's afraid he's going to hurt me. He's very worried about that. And so I think that reassuring your partner that they're not going to hurt you, that you'll tell them if it hurts, and we'll figure out a way to deal with it. There are, obviously I didn't have very much to talk about this. There's a lot more to discuss. And that's why you should talk to a gynecologist.
Yes, I agree. You should talk to a gynecologist. And also I think people will say the brain is the largest erogenous zone. So get creative. It doesn't have to all be about vaginal penetration. And maybe people get stuck in patterns. Again, I talked about relationship patterns that change. This may be one of those patterns that change. And suddenly you find yourself talking about topics in your relationship that were on autopilot for a very long time. But look at it as an opportunity to use those shared goals of enjoying each other and enjoying that intimacy, taking longer, being creative, and you actually may have a more enjoyable experience overall because you're no longer on autopilot.
Questions?
I did see a gynecologist and they told me not to get on an estrogen enhancer. I go, okay, he's going to help me with this. And I'm really glad to hear that there's other things to do because, like you said, my desire for sex is not as what it used to be, of course, in my 20s, but but I don't feel that it's fair to my husband not to be able to help him too in his ways. So the ring you say is an estrogen enhancer, correct? I
Well,
take letrozole every day.
Yeah, so the vaginal estrogen ring, the 3 different vaginal products are all adding estrogen, and the vagina is the only part of the body that I know of that can actually age backwards. You can take a vagina that looks like it belongs to an older woman, give vaginal estrogen, and the vagina will look younger and function younger. So it works directly in the vagina, but it's not going into the bloodstream. It's not increasing blood estrogen levels. So that's why the oncologists are comfortable with it. Not all gynecologists may not be as comfortable with vaginal estrogen in their breast cancer survivors as others. I am a certified menopause practitioner, so it's an important part of my practice and it's an important part of my knowledge to keep up on the latest information. So it's an unusual person that I would deny vaginal estrogen to, unless their oncologist said no. But yes, the other approaches will help. They don't help quite as much as the vaginal estrogen does.
Thank you.
We have a question from the online chat. This is an area easy to give up on when you are not in a relationship. It's hard to maintain and to hope that any new relationship would ever find you desirable with metastatic cancer. Can you address the issues for those women not in a relationship already living with the diagnosis?
Well, I think that it's good for women who are not in a relationship to continue to pay attention to their vulva and their vagina because it's an important part of your body. You know, you go to the dentist every year, you get your eyes checked. Why shouldn't you be paying attention to your vagina and how well it functions? So what somebody can do who is not in a relationship is to use the moisturizer, use estrogen if they need it. They can use dilators. So I'm going to show you what vaginal dilators look like. They come in graduated sizes. So you start with the smallest one. You work up to the next one. It's hard to do with one hand. Eventually you get to the largest one. This is not even the largest one, but that's what's in this kit. So then you use that 10 or 15 minutes a day with lubricant, and then you gradually can allow your vagina to stretch. So that's something that someone can be doing. They can use sex toys. They can it's reassuring to find that your body has the ability to respond. And you may have something to say about that too.
Yeah, no, I would concur, and that you don't have to be in a partnership to be a sexual human being and to enjoy your sexuality. So take advantage of that as being a whole person. Don't feel like you have to cut yourself off. And then I think there's the whole other can of worms with thinking about dating or finding a sexual partner while living with metastatic breast cancer, where you have this uncertainty with the diagnosis. And then there's all the uncertainty of dating in a new relationship and getting to meet someone new. So I would say, don't limit yourself. I don't think that dating is off the table. I think you can date and be open about your experience and what you're going through. And I have a friend who likes to say, there's a lid for every pot. So there are a lot of folks who say that nobody would want my situation. No one would find me desirable. No one would be interested in that. And then the next day I'll have an appointment and someone is saying, gee, I wish I could just find a person like this, like the exact person I was talking to yesterday. So I would say that be open, just to stay open to other people and other new experiences. You don't have to rush into anything, but just being honest and open with people. And continuing to enjoy your own body and enjoy your own sexuality.
And use condoms if you're in a new relationship, even if you have no risk of getting pregnant.
STD testing.
Hi, I just wanted to introduce a product to people that helped me. I was diagnosed at age 31, so kind of in the prime of my sexual health. And it was devastating because there weren't any resources. And the insurance company gave me a tiny, tiny pill to cut in half and insert in my vagina. So I was desperate. I found a startup company called the O-Nut. And it's so I was having problems with depth because my husband just wanted to go all in. I was like, it wasn't okay. And so I found this company that has, it's like in a little accordion, a little seed that goes over the penis, and then it helps prevent the person from going too deep. And I found that to be extremely helpful, I thought I was sexually active, and anyways, now I am not using it, but in the beginning of my journey, I definitely found the O-Nut to be very helpful.
That's an O-H, like, oh.
Yeah, O-Nut. And it's actually by the Pelvic People Company. The Pelvic People. And then also
that's
I
in my
wanted to
longer
say
talk.
that the coconut oil is not, from my understanding, shouldn't be used if you're using condoms because it does break down the condom.
That's correct.
Okay, excellent. Thank you.
Thank you all so much. I'm sorry we've run out of time, but thank you. Really appreciate you joining us. Lunch is across the hall. We will.
Welcome back. So now that we've all eaten, we're going to talk about what we should have eaten. But yeah, we're having a great time here. It's been really nice to talk with some of you during the breaks. We continue our journey, what is life? Today is going to be, or this next session is going to have 3 of our speakers, and the theme is self-care at home. And for our first speaker, we're really delighted to have Dr. Heather Greenlee here. And she's the Director of Integrative Medicine at Fred Hutch. She's also a professor in cancer prevention. She does work on survivorship, integrative medicine. I'm probably really underselling her, but I don't want to cut into her time too much. She's going to speak to us about nutrition, and then we'll have other speakers on exercise, physical therapy, and then meaning making and spiritual well-being, and then we'll finish up with QA. We're add 15 minutes, 15 to 20 minutes to what you see on the agenda, and that's where we're at. So just without further ado.
Good afternoon, everybody. The lunch looked delicious. No judgment. It looked wonderful. Welcome back to Pelton. I'm really happy that all of you made the time to come and talk with us today. So I get to talk about food and nutrition, which is what I love. And I just want to get started by putting this slide up, which might be where a lot of you sit, and that there's a lot of people have questions before a cancer diagnosis, but certainly after a cancer diagnosis and after a metastatic cancer diagnosis, what should one be eating? What is nutrition? There's a ton of information out on the web. There's a lot of well-meaning family, friends, and sometimes healthcare providers who offer you information. And some of that is evidence-based and some of it's not. We've seen with a lot of people that there can be a lot of hope put into certain nutrition and dietary patterns. There also can end up being actually a lot of conflict between family members and loved ones because people don't always agree on what should happen. And so this can be compounded when people are experiencing side effects of treatment, when they're trying new medications, when they're just feeling tired, when they don't have the resources to maybe eat the ideal dietary pattern that they want. And so we spend a lot of time in our clinic trying to debunk some of the myths that are out there and really trying to support people so that we can think about food as medicine. That's a concept that's been around for a long time, but the National Institutes of Health, the National Cancer Institute is actually starting to solicit some research focused on food as medicine. So we're really excited about that. So I'm hoping that I can help answer some questions today and help solve it so that you're not this woman in the middle wondering, what should I be doing? So what do we have available here at Fred Hutch? So we actually have quite a few resources focused on nutrition. The main thing that we have is that we have nutrition clinical consults. We have an excellent team of registered dietitians with specialty in oncology in our clinic. And those are available to patients anytime after a cancer diagnosis. And so if you haven't met with our team yet and you're interested in that, I highly recommend working with those folks. The other thing that we do then, so in our work is in integrative medicine. I came here to the Hutch about 7.5 years ago to build our integrative medicine program. And what we do there is that we spend a lot of time talking with people about using food as medicine in conjunction with all of the other things that they can do in their life. Physical activity, mindfulness, mindfulness-based stress reduction, mind-body medicine, acupuncture. We do a lot of work with patients around the appropriate use of dietary supplements. So we also have our integrative medicine consults. Our team does a lot of research, and other investigators here at the Hutch do a lot of research focused on nutrition and cancer. We've been leaders in the field in nutrition and cancer prevention for a long time, and now we're doing more work around the use of nutrition following a cancer diagnosis and looking at how that can affect both quality of life and also affect some long-term cancer outcomes. And then finally, another thing that we offer here at Fred Hutch is our website called Cook for Your Life. And so this is a website, and I'm going to talk about this in more detail. This is a website that was started in New York City by who was my community partner in crime, I call her, Ann Ogden Gaffney. And she is now a 3-time cancer survivor. And she left her fancy career in the New York fashion industry and decided to start a nonprofit focused on offering evidence-based nutrition information for patients following a cancer diagnosis. And this led to a really wonderful research collaboration between us. And when I moved here to Seattle, we had an active research portfolio going using what turned into her website called Cook for Your Life. And then she decided to retire. So I inherited her website, and now I'm a webmaster, which I did not think I was going to become that in my career. And so now we have this great resource here to everybody here at the Hutch and globally. So I'm going to talk more about that as well. So we do have a lot of resources here for patients. So one of the things I want to do is to give you some grounding in really what our basic nutrition recommendations are and where those come from. There's an organization called, oh, didn't pop up there, there you go, called the American Institute for Cancer Research. And AICR is an organization that's been around for a long time, and they are the group that collates all of the nutrition and really physical activity research that's out there, both animal model studies, in vitro studies, but most importantly, human studies, to find out what are the recommendations for both cancer prevention and cancer survivorship. And so this is their general set of recommendations, which I think you can see, but I'm just going to walk you around this circle. So the first one is to achieve and maintain a healthy weight. I'll say there's actually a little bit of debate about this right now, but the idea is to achieve a healthy weight and work with your healthcare provider to determine what that is for you. The second thing, and this is if there's one thing that I could ask everybody to do, even though I'm talking about nutrition, is to be physically active. And maybe Dr. Hunter is going to talk about that. But this is really, 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 really vital to everybody's health, both from a cancer perspective as well as anything else. As we all age, our muscle mass rapidly declines, and so we have to fight to keep that on. But being physically active, following the Surgeon General's guidelines of 150 minutes per week of moderate to vigorous physical activity is good for everybody. The next thing is talking about specifically about food is really to eat plants. And so eat a diet that's rich in whole grains, vegetables, fruit, and legumes, and to eat as much of that as possible, limiting consumption of fast foods and other processed foods that are high in fat, starches, and other sugars. Limiting consumption of red meat and processed meat because we've actually seen, especially for some colorectal cancers and some GI cancers, that can definitely increase risk, but we haven't seen health benefits of red and processed meat. Limiting consumption of sugar sweetened drinks, limiting alcohol consumption. Alcohol is a carcinogen. And a few years ago, the American Institute for Cancer Research and the American Cancer Society came out with guidelines stating that individuals, anybody really should drink no more than 1 serving of alcohol a day, and to decrease that even further if possible. This is where we get a lot of questions in integrative medicine, not to use supplements for cancer prevention because we don't have data suggesting that they're useful either for cancer prevention or for cancer treatment. And then this is actually for primary cancer prevention. It's important to breastfeed. And then the recommendation is following a cancer diagnosis, following these recommendations. And so this really provides the framework for guiding our research, but also guiding our clinical recommendations to patients. So this is the Cook for Your Life website. We have a weekly colorful picture that changes, and we think it's really important. A lot of food, there are a lot of visual cues, and so we think it's really important for food, especially when people aren't feeling great, for us to have appealing looking pictures up there. And so on the website is available in English and Spanish. We get about 2.5 million unique users to the website per year. And in fact, our Spanish usage of the website is growing, and we get a lot of actually traction globally with the website. So we're excited to provide that service. The website has 3 different areas, one focused specifically on cancer prevention, one focus on using nutrition during treatment to help manage and mitigate some of the side effects of treatment, and then the last one is to look at cancer survivorship. We have on here over 1,100 recipes, 400 articles on nutrition and cancer using evidence-based information, and we have about 300 videos, culinary videos, a lot of them my colleague Anne, cooking in her kitchen and showing you how fun and nutritious cancer can be. You can't really, or not cancer, I'm sorry, fun and nutritious different recipes, sorry. At the top, you can't really read this, but there's different ways to select based on culinary preferences or dietary preferences. So if you're gluten-free or if you're vegan, you can click on that. If you want to do something that's quick and easy, you can click and look for quick and easy. If you don't have access to a stove, you can click and say that something that's a no-cook meal, or if you only want to use 3 ingredients. And so depending on if you're somebody who wants, to spend, 3 hours preparing dinner, you could do that, or you could do something that's maybe a little bit more efficient, which is what a lot of people want to do. So I'm now going to just blaze through some common questions that we get about nutrition and point you to some resources here. And there will be time with Q&A afterwards, and I'm happy to stay and talk with people afterwards. So the first question that we get all the time is, do I need to eat organic? And so we have an article on this on Cook for Your Life. Here's a QR code if you want to scan that, if you want access, or you can just search on our website for that. But really what our bottom line is that it's important to eat fruits and vegetables. That's one of the best things that we can do from a cancer prevention and cancer survivorship standpoint. And a lot of people can't afford to eat organic. And so some people restrict eating fruits and vegetables because it's not organic, and that's not what we want. The most important thing is to eat those fruits and vegetables. And if people can afford organic, that's great. It's not harmful. But especially for adults, we're not concerned really about organic eating. We think that that's probably much more important for young children when they're involved in, when they have a bunch of neurodevelopment things going on in their bodies. The next question that we get, pretty much everybody who walks into my office, does sugar cause cancer? The answer is no, it does not. If you go online, you'll see a lot of people writing a lot of books and making a lot of money off of this claim. We do not think that sugar causes cancer. Carbohydrates and plants and have natural sugars in them. Those are really important for our body to do and engage in all of the metabolic and physiologic functions that it has. And so now certainly, as you saw in the AICR guidelines, we don't want people, we're encouraging people to decrease processed sugars, sugar sweetened beverages, but trying to cut out all sugars from diet just actually isn't sustainable at all and actually isn't healthy. So it's really important to understand the nuances of what that means. The next question is it okay to eat red meat? Well, going back to the AICR guidelines, the recommendation is really to decrease red and processed meats as much as possible. It's okay to eat it occasionally, but it's not, we're not seeing a lot of health benefits from this. Now people say, well, what about eating, pasture raised beef? Again, that's an affordability thing for a lot of people. The other thing that, and if our dietitians were here, they would say protein is often incredibly important during treatment. And if that's the only way that somebody's going to be able to get in protein into their diets, then that's important to do. So again, this is where having a nutrition consult can be really helpful. But there are a lot of other animal proteins that we focus on first before thinking about red meat. We think about fish, we think about chicken with the skin removed. Those are really, those tend to be healthier forms of animal proteins. Next question, what should I do during treatment? So again, if our dietitians were here, and they're really the people to talk about the specific recommendations during treatment, they wanted to focus on hydration, making sure that people are staying hydrated during treatment, getting enough calories in during treatment so that people aren't dropping weight, and also to make sure that people are getting enough protein. And they can actually do a specific calculation for everybody, for each patient, to determine how many grams of protein people need to be getting in their diet. So that's important. So this is some of the information that we have on the website. We have a collection of recipes dealing with these specific and most common treatment side effects: low appetite, constipation, diarrhea, difficulty swallowing, that feeling of early fullness or early satiety, fatigue, mouth sores, nausea, and taste changes. This is the big question to see if I can get this to work. So I'm going to ask you all some questions about what you're interested in, because we're trying to get some information and some feedback on where we can take some of our clinical programs going forward and where we can potentially direct some of our research. So for those of you with a phone who want to do this, you can either scan the QR code or you can go to slido.com on your phone and you can type in this code. And let's see if I can get this to work. Did it work? So the first question that we have is, here we go. Would you be interested in taking an online nutrition cooking class specific to women with metastatic breast cancer? So we conduct some online classes. Before COVID, we did these in person, but now we're doing everything online. And so we want some feedback on whether or not there'd be interest in this. And so we want to know if people would be interested in having it be specific to women with metastatic breast cancer, or if it should be all breast cancers, or not interested. So it looks like we have about half of the half of you would be interested in something like this. Okay, great. The next question that we have is, we do culinary and not shows, we do culinary classes where we try to do a lot of hands-on cooking, but we've noticed that sometimes when people prefer to engage in a nutrition and cooking program, that people watch from their couch, or that they're engaged in their kitchen and they cook along with the instructor. That is pretty interesting. All right, I'm going to give it a little bit more time. I don't know.
You can get on the free Fred Hutch Wi-Fi as a guest.
And you can also just tell me what you want to. Yeah, yeah. Oh, it was gone? Oh, I went too fast. Okay, let me go put this back up. There you go. Can you see that? Oh, sorry. I'll leave that right there. Can I move on, or are people still putting this in? Yeah. Okay, sorry. My kids tell me that I'm too slow, so. All right, I'm gonna, just for the interest of time, I'm gonna move us along. Ooh. There we go. Okay, it looks like the couch is looking really appealing to about half of you. So that's good to know. That's good to know, because we're trying to figure out how to develop resources for everybody. Okay, the last question I have is, if we, for these, let's say we did do a class that would be a cook-along class. If we provided a grocery list for this class, how would people prefer to get their groceries? And the reason we're asking about this is we know with COVID, there was a lot of new online delivery services, and we're trying to understand if this is something that would be useful and appealing to people. So would people want to shop for themselves at a local store, shop for themselves online, have groceries selected and delivered by a delivery services, or would people not participate in something like this? It looks like a lot of you are happy to shop at your local store. It's good for local commerce. And then some people are interested in having them selected and delivered by a delivery service. Okay, great. Thank you so much. All right, I'm going to now go back to my slides. If I can.
Should we close the website?
Yes, you can close it. Thank you very much. I appreciate that. Is that this one? No. Just swap it, please. There you go. Okay, great. Thank you so much. All right. Okay, so to our take-home messages, Fred Hutch provides multiple nutrition-related resources to our patients. We really promote an evidence-based food-first approach to nutrition along with a healthy lifestyle. Cook for Your Life is a readily accessible resource for anyone, and we think you should eat a lot of plants. So, so if you're interested, you can sign up for our newsletter on Cook for Your Life. This is the QR code, or you can just go to our website, cookforyourlife.org. And it pops up as soon as you go to the website. And we have some recipe cards and some nutrition related information, Cook for Your Life related information on the table in front here. And then there's just a couple other resources that we always point people to when they're interested in reading online about nutrition and cancer. We think it's really important to go to evidence-based resources. The American Institute for Cancer Research and also the American Cancer Society have excellent information. So thank you very much for your time.
Thank you so much. Dr. Greenlee will join us for Q&A, but in the interest of time, we'll move on to Dr. Hunter, not me, someone I would be proud to be related to, but am not, who is our physical rehab medicine doctor who works with cancer rehab. I have referred many, many patients to her, and they are uniformly very satisfied. And so she is here to talk with us about exercise.
Thank you, Dr. Hunter. I just so I'm going to give a talk on physical activity and exercise, but really framed in the kind of idea of resilience, because I think everyone would probably agree that exercise is helpful. But the idea of exercise in the setting of cancer treatment is that it's a way to kind of build up physiologic reserve to be able to overcome stressors or challenges that come with treatment. And I'm just going to start with this kind of physics definition of resilience, this ability of an elastic material such as rubber to absorb energy and release that energy as it springs back to its original shape. And as I talk about resilience, I'm going to frame it in this idea of going on a hike. We're in the Pacific Northwest. We're going to stay on theme because I think resilience is something that's not necessarily intrinsic, but something that we build and grow over time. And with this idea of physical activity, there's going to be a lot of P's. We're going to talk about preparation, pacing, and perspective. So in this visual, we have this woman who is about to go on a hike. She may have never done this hike before, but she is prepared. She's packed her backpack. She's got some fluids. She's got some snacks. She's done some cross training. Maybe she's hiked before. So she knows herself that she can tackle what is to come in the next few hours. In that same way, I would say no one's really prepares for a cancer diagnosis, but all your lived experiences, challenges that you've overcome have built up your resilience, whether it's psychological or physical. And I think both are so integrated when we talk about the benefits of physical activity, because physical activity ripples into so many domains of life. That's not just muscles, joints, and tendons. So in that sense, I would say all our patients come in with this resilience, and our goal is to try to fine-tune that to be able to overcome future stressors. And let's talk specifically about the physical activity that we try to make more robust with targeted exercise. But in terms of a little history, mobility and exercise wasn't always recommended in terms of healthcare. A long time ago, what was recommended was this idea of bed rest. And it wasn't until the baby boom where hospitals were filled with women on labor and delivery units, and they realized when they ran out of beds, the women who were walking around right after delivery were actually doing better. Less risk of blood clots, able to go home faster. And it kind of helped emerge this idea of exercise research in healthcare to better understand the benefits of moving. And eventually in 2022, there were specific guidelines that were recommended. I know this is going to sound very innovative, but oncology providers should recommend aerobic and resistance exercise during active treatment to mitigate side effects of cancer treatment. So it's taken years and dozens of exercise trials to come up with this statement that I think most of you would probably agree with. But again, we've learned that exercise and physical activity not only helps bone strength, heart health, growing muscles, improving muscle quality, but again, ripples into so many domains related to quality of life. And that is fatigue, so improving your energy levels, better sleep, mood, decreasing your risk of falls, and what I would argue most important, doing things that you want to do. And so these exercise trials have kind of concluded that there's this ideal goal of how much physical activity that patients should be doing. And it's not so different from the general American Heart Association's recommendations for activity, but it's 150 minutes of moderate intensity exercise per week and a few resistance exercise days per week. And I want the big takeaway from this talk, not that you should leave today and go from not doing activity to all of a sudden jumping to 150 minutes of activity, but realizing that there's many benefits of physical activity that go beyond muscle health. And our goal is not to start this right away, but figure out a plan to start incorporating physical activity into your day that makes sense. Dr. Greenlee mentioned nutrition is medicine. Another thing that's often stated is that exercise is medicine. I think both are critical to help fuel our day. And I practice and believe in this idea of an exercise prescription. So when I see patients or when our rehab team sees patients, we're not telling everyone to go do 150 minutes of exercise per week, but we're trying to figure out what kind, how much, how often, what kind of exercise is going to give each of you the best bang for your buck. If you're experiencing a side effect of treatment, if there's something that's challenging for you to do, we want to tailor that prescription, just like a prescription for medicine that you get from your physician, to better hone in on what exercise is going to actually help you achieve those goals related to quality of life. Because that dose is really important, because especially when patients are experiencing fatigue, if you overdo it, you may not reap those benefits. And that's where pacing comes into play. So just like this hiker who's starting this hike, she's not like racing up the hill or the trailhead. She's pacing her day to enjoy the hike. And when I talk about pacing, I think of this as an idea of being energy wise. If you start your day with energy in the gas tank that you're fueling with good nutrition, we don't want you to empty that gas tank by going on an hour walk and not being able to do everything else you have to do or that you want to do. That hiker will go on her hike, but leave gas in the tank to be able to drive home, maybe make dinner, do some laundry, all the important things that she may need to do in addition to that hike. And so while there's benefits of exercise and maybe this idea of X amount of minutes per week, we don't want patients to drain their energy tank just to exercise for the sake of exercise. The goal is to have a tailored approach to do enough physical activity that it's going to reap benefit. So I think of it as a pre-planned strategy, just like an athlete who's training. They're not going to wipe out all of, let's say, a pitcher who's about to, I don't know, let's say it was a pitcher who's about to play the most important game of their life. They're not going to drain their gas tank and pitch 95-mile-per-hour fastballs every day leading up to that game. They're going to pace their training to kind of be in an ideal state for that game. A critical piece of pacing is finding your baseline. And it's a new baseline. It's not the pre-cancer baseline, but it's about figuring out what amount of physical activity can you tolerate that is reproducible from day to day. And once you have your baseline, then we can make slow incremental improvements to that to get to that goal of, let's say, 150 minutes of moderate intensity exercise. Many individuals, whether they're athletes or patients, are more than motivated to return to physical activity. But if you overdo it, we often see that individuals will seesaw between overexertion and rest. And in the definition of cancer-related fatigue is that this is an overwhelming sense of exhaustion that's not reciprocal to rest. So if you overdo it with a walk or an hour yoga class or Peloton class, and you need more than a day to recover, that's not sustainable. So we'd rather tell patients to cut back, find an amount of exercise that you can do on a good day and crummy day to not seesaw. But once you find that new baseline, then you can kind of make slow incremental improvements in terms of how much you're walking, the speed of incline that you're walking to achieve your physical activity goals. We also recommend avoiding this idea of seesawing between too much activity and rest to avoid things like injury or exacerbation of other symptoms like fatigue. Some strategies that we know are helpful for starting physical activity or increasing your physical activity is to pair it with things that you enjoy. I love the idea of exercise snacks because I love snacks, period. So the one thing I tell patients to do is if you do a sit to stand from wherever you're eating breakfast, lunch, or dinner, which is basically a modified squat, you do 5 sit to stands with breakfast, 5 with lunch, 5 with dinner, you've done 15 squats that you otherwise wouldn't have done. And it's basically interval strength training because you've done it in intervals throughout the day. You can also pair exercise with listening to an audiobook or music, hanging out with people that you enjoy being around. And there's a huge kind of constellation now of mobile health apps or
Fitbits or exercise trackers that, if you're a numbers person, that some individuals really enjoy keeping track of. So some pearls related to exercise snacks. Going from 10 minutes of activity to 20 minutes of activity is double your activity. So when we talk to athletes about increasing mileage or increasing training, we tell them 10% max per week. So once you find that baseline, we want a pragmatic goal of increasing per week and setting yourself up for success. So even with a strength training exercise, if you're doing 1 set of 10, instead of doing 2 sets of 10, do 2 sets of 6 for a week, then increase to 2 sets of 7. And the goal is that that will set you up for that incremental improvement in duration, time, frequency, rather than overdoing it. The guidelines that we discussed in terms of physical activity were 150 minutes of moderate intensity exercise. And a question we often get is, what is moderate intensity exercise? There's fancy ways that we can monitor heart rate, how efficient your body's working with exercise, but a lot of our exercise trials have concluded that patients are way better gauges of their own self-exertion than some of the fancy tests that we do. So what that means is if 0 is rest and 10 is like huffing and puffing max exertion, if you were to gauge yourself at a 6 or less, that is a light activity or moderate intensity activity. So with activity, especially if you're engaging in a new sport or new exercise routine, try to gauge yourself at a 6 out of 10 or less. Moderate intensity aerobic exercise is also described as being able to carry a conversation when you're walking with a brisk walk. So if you're able to sing a song, you can like up the pace, but if you're huffing and puffing, the goal is to be able to carry a conversation, which is why it's also great to walk with someone you like. And the last thing I'll touch on is this idea of perspective. Because many patients will come in to see myself or our physical therapy team saying, I want to get back to my baseline. I want to be able to go back to X, Y, or Z. And a quote that I really like is this idea of from Maya Angelou that says, I can be changed by what happens to me, but I refuse to be reduced by it. So I think perspective when it comes to physical health and activity is this idea of being able to move forward or progress forward. If patients say, I want to go back to playing tennis, I think the perspective is we want to move you forward to playing tennis now as a cancer survivor or under treatment. And I think that perspective is really important when it comes to resilience, because it's not this idea of bouncing back, but progressing forward. And I'll end with that.
Thank you so much, Dr. Hunter. And last but not least, we have Ray Wiseman, who is a spiritual health clinician here at Red Hutch. She spends a lot of time with breast cancer patients. So we're very thankful to have you with us today, Ray. Thank you.
Hi, everyone. So I'm Ray Wiseman. I'm one of the spiritual health providers here at the Red Hutch. I've been here
Ray, I'm sorry to interrupt you, but yes, that's exactly right. You want to, I can tell already that you're the kind of person who wants to walk around.
I am the kind of person that wants to walk around. So yes, I've been at the Hutch for 7 years, almost 7 years. And yeah, I just wanted to talk to you a little bit about what I do here and just kind of the culmination of about 18 years in this field. And what I like to say is take what works for you, leave the rest behind. No two people are the same in their spiritual or emotional health. So yeah, basically what I wanted to just start is by introducing spiritual health as I understand it. So what I like to say when I meet a new patient is that spiritual health means something different to everybody because we all have our own backgrounds and belief systems. But essentially, I'm one of the people on the medical team who's here to set up a safe space for folks to share and process whatever's on their heart or mind. And my job is mostly a lot of active listening and reflection and helping folks to get connected or reconnected to their own sources of peace, meaning, joy, hope, strength, faith, if that's your thing. And it doesn't have to be, but I want to say a little bit more about faith. Because faith can be in a higher power or God, but it can be in a lot of other things too. And all of those things can really help us out along this road. So to start with, I like to talk about faith in self. Faith that we'll be able to get through whatever hardships we're going through, faith to be able to retain a sense of peace and joy, dignity, and forgive ourselves if we don't. Faith also means faith in others, like your friends and family, to care, to stick by you, to not mind if you need some help, to feel good about helping you, because that's usually the case. Faith in your medical team and the people who are taking care of you. Of course, can't be blind faith, right? We always gotta be part of our team, but it's really important to be able to trust your medical team, and being able to talk to them about that is a really important part of faith too. And then faith in the transcendent. You can call it God or higher power, the universe. A lot of people around here call it Mother Nature, just maybe a higher order of things, the natural laws of the universe, all of those things. Faith that there's goodness and love in the universe. Faith that we're trying to make the world a better place. So all of those roads to faith are really important, and they can give us a sense of peace as we go through some of the challenges in life. So. I also want to just take a moment to just acknowledge the grief and loss that comes with this disease. And one of the things that I do here is just hold space for that grief and loss. I really like this poem, and I just wanted to read a little bit of it. Let us agree for now that we will not say the breaking makes us stronger. Let us promise that we will not tell ourselves time will heal the wound when every day our waking opens it anew. Perhaps for now, it can be enough to simply marvel at the mystery of how a heart so broken can go on beating. So yeah, as a spiritual health provider, sometimes people resonate with the "a dodge what doesn't kill me makes me stronger," but most of the time it's not helpful. So everybody grieves in their own way. I have a picture of the stages of grief that can be helpful to understand where we're at. But one thing we found, and that's really important, is that you can loop around, go back and forth between acceptance and anger and bargaining, and it's just 2 steps forward, 1 step back, and that's okay, because it's a really important part of the process, and it helps us know what we value. And so I just want to affirm that, and also just talk about one of the ways that grief can it can bring us together. I have a picture of Inside Out. This is a really great movie for learning about emotional intelligence, and if you haven't seen it, I really recommend it. And one of the things that we learn in this movie, as I'm sure most of you have, is that sharing our grief can be so helpful, and just bring us together. And so I want to just kind of riff on that a little bit, and just take 15 seconds to invite you all. I know this is really daunting. You don't have to if you don't want to, but just if you could just like look around, say hi to somebody next to you. I don't know if you can, but just like share one thing that you love. It could be your pet, it could be your favorite food, just to make a connection, right? And I'll tell you why in a little bit. So 15 seconds, go ahead. Okay, awesome. We'll just wrap it up a little bit. Thank you all for participating. All right. I'm so glad that you're taking this time to say hello, and we'll get back to the program as usual. Okay, thank you. So love, yeah, thanks for sharing something that you love. And I wanted to take that moment to talk or to give that example, and then to take this moment to talk about the ripple effect that I really like to remind everybody. None of us exists in a vacuum. Every moment, every millisecond of every day, we're affecting the air molecules, we're affecting the eyelash mites that live on us, our gut mite, we're affecting everybody around us. And so it's the ripple effect. And sometimes when we find ourselves scared, angry, sad, alone, it can be really helpful to remember that we have no idea how much we have affected the lives of everybody that we came in contact with that day. Every kind word or smile or acknowledgement of, the grocer at the grocery store. It goes on and it can change, the entire world. And so, not that we have to smile, not that we always have to be nice, but we just don't know all the ways that what we did in the world will affect other people. And so that's when it comes back to faith, faith in self, that we did the best that we could. And so I just like to remind people, don't ever underestimate your effect on the world. It's really profound in ways that none of us will ever know. So, finding your spirituality, in case anybody was wondering, some of us maybe have an idea of what our spirituality is. Some people may be more traditionally religious and have a well-defined path, and a lot of us are piecemealing it together. So sometimes I just like to ask some questions of some of my patients and friends and everybody that I ever come in contact with, to try to help them to tap into where they connect spiritually. And so just wanted to throw out there, that our spirituality can be in a lot of things. It's just where you find meaning and connection. Is it in the love of your kids and grandkids or friends? Some people find spirituality in the garden, in the cycles of nature, or in art. That can be a form of spirituality. And if there's anybody out there who is wanting to connect more spiritually, one of the recommendations that I have is to make space for spiritual experiences. Sometimes this can look like, going out and taking a walk or sitting out in nature. I know it's cold here. That's a bummer. It's going to be harder. Some people have a little altar in their house, right? Where just like a table where they have a candle and maybe a picture of somebody they love, or little, tokens of whatever your values are, or whatever's important to you. And then just, sitting in that place, right? And being still, getting a cup of tea, putting on some nice music, incense, all of that stuff is just kind of setting the stage for us to be able to connect spiritually and connect with something, beyond, outside of ourselves. Awe and wonder is another clue to a lot of people's spirituality. Where do you find a sense of wonder at the mysteries of the universe? There's so many mysteries in the universe. If you haven't found them, I'm sure you know. Unexplainable events, gut feelings, intuition. Science doesn't know a lot about this stuff yet. Quantum physics, dark matter and dark energy, the origin of life, all of those things are still left to be discovered. So those can be routes to finding a sense of spirituality as well. And so some of us have like a strong eye for like color or, you know, visual imagery, and some people hear a still small voice. And like I mentioned, some people have gut feelings and intuitions. Just trust that and follow that, and that could be a route to deepening your spiritual life and your spiritual health. And they wanted me to talk about meaning making, and it's a tricky subject, but I wanted to just throw out there that meaning making is really unique to everybody, right? We all have to find our own sense of purpose and meaning in life, but it can be anything. Yeah, there's one example of a study in the University College London. We followed 900 participants for 8.5 years, and they found that people who had a sense of purpose had 30% higher chance of survival. So it helps, right? Because it gives us something to get up for. It gives us something to go take that walk for, to eat better for. And all of those things collectively can help. You know, we just heard about nutrition and exercise. So, and these are some of the meaning making examples that some of my patients have mentioned. You know, the purpose of exploring what life has to offer, trying all the new foods you can, being a part of something bigger, some clinical trial that, you know, that you are contributing to us finding a cure, and spiritual and emotional growth, other forms of meaning. There's a lot of them. You know, learning how to receive care can be really important purpose, right? Because we can teach our kids and our family and friends, you know, how to be a good caregiver, and then we can teach them also how to receive care, because they're going to need to someday too. They're going to need to be in a position where they get driven to their medical appointments, and so that can be a meaning or a purpose in life as well. Self-care. I hated the term self-care for the first couple of years of this work. I don't know. I mean, and I'm sure some of you can relate, right? Feels guilty, and sometimes it's just hard, and you don't want to care for yourself and do all the things. Sometimes it is hard, exercising and eating well. But it's a spiritual practice, and it is sometimes work, but it can be so incredibly helpful, obviously. Because we're going to be the only ones all the time with us. I mean, even if you have a partner or child or a parent that's attached to the hip, you know, they can never be there 24/7, but you can. You can always be there for yourself. And one of the analogies that I really like for self-care is instead of pouring from your cup to give to others when you're taking care of others, I heard a cool idea of where we take our cup and we go find this eternal font, right? Maybe it's spirituality or love or whatever. And we go fill our cup with this eternal font. Maybe this is spiritual practices, right? And then the overflow from your cup, you can go and fill other people's cup with. That way, you're not pouring from an empty cup, and you get to still stay full. And so it's basically like the more that we take care of ourselves, the more we can like radiate out that love, that kindness, that compassion for others. So taking care of yourself is taking care of other people. It's a nice trick. I'm just gonna list some other ways spiritual health matters, because I have some cool, cute dogs that are doing it. Meditation, obviously awesome. One of my friends put it this way. She says, I meditate. No, this is one of my patients. She says, I meditate because it reminds me that doing nothing is okay. I've intentionally set, 20 minutes out a day to do nothing, to just be. And that's a really important reminder for myself. So that it is okay. We're not, what did I say? We're not human doings, we're human beings. Massage. If you can get a massage, go for it. Get it. I really highly recommend this at any chance possible. Some physical therapy clinics also have massage therapists on staff, and this can be covered by insurance. Any kind of relaxation is it's a real big part of spiritual health. yoga, stretching if you don't want to make it yoga self-havening. I'm going to teach you all this really cool self-havening trick, and it can be really helpful. If you don't mind doing it with me, I'm just going to show you this with my phone. It's just this. I already feel so much better. I don't know about you. And it's just something we can do anytime, you know, and it just triggers that oxytocin release, reminds us that we're here for us, for ourselves. So I love showing that. Yeah, so and just, you know, never underestimate the healing properties of rest and relaxation. Yeah, anything you can outsource to other people, please, you know, do if you can, because for every minute that you're not vacuuming, you could be self-havening or meditating or, you know, relaxing, taking a bath, you know. So if you got the means to take people up on their offers to help, or hiring somebody, it can help a whole lot. So yeah, I mean, this is basically the conclusion, but basically I just want to remind you all that you're each unique puzzle pieces in this universe, right? There's no other pattern exactly like you. And I want to say this in the context of how important it is to have self-compassion and self-acceptance and self-love. Yeah, like the ripple effect. We never know what we are really here for. There are a million purposes every day that we're here for. But if there's one thing that I've heard more than anything else in my 18 years in this field is it's just that we're really hard on ourselves a lot. And sometimes it can be motivational. So, you know, if we berate ourselves when we don't live up to our, you know, whatever expectations or standards, that kind of internal voice that is cutting us down, it seeps in and it never shuts up. It never will be satisfied. If you know, just keep feeding it, doing more things that the nasty voice said, like it will always keep going. So if I can, you know, suggest one thing is just to love yourself and to accept yourself as much as possible. I like to put my hand on my heart every morning and just say, I love myself, I trust myself, I forgive myself, and I accept myself. So yeah, just above all, be yourself. And that's exactly what you need to do. So that's about it. Thank you.
You so much. I've had one request. If you can just stay put, because that's where you're in front of the web camera. If you can just re-demonstrate the self-havening exercise. We can all do it with her if we want. All right, can we be joined by our other panel members for just a quick Q&A? And while they're having a seat, we have a couple comments from the audience. There were expressions of appreciation, Rand, for the poem that you read, and also just generally for the talk itself. Heather, there was a question about the keto diet, if you wanted to respond to that. And then Dr. Hunter, sorry, I'm not doing a good job of being consistent about calling people by their first name, their doctor. Hanna, about the questions about fear of injury in the metastatic setting when you're exercising.
So good question about the keto diet. It's very popular. A lot of people have questions about it. We don't advocate the keto diet. We've spent a lot of time talking with our nutrition team about that. The reason is that we're actually concerned that a lot of people are going to lose too much weight, especially when they're going through treatment, and lose muscle mass and lose. And the other thing is that a lot of forms of the keto diet restrict fruits and vegetables and whole grains and legumes, which we think are really important for healthy metabolism. And so there's sort of a keto light version that people could consider, which is eating, eating enough protein, either plant-based protein or chicken or fish, but really eating whole carbs, whole grains, but not restricting all of the carbohydrates. There's actually somebody whispered a question to me too that I'll just answer to, which is about soy. There's a lot of questions that we get about soy and whether or not that's safe. There used to be this concern that soy was a phytoestrogen and could actually increase risk for breast cancer or increase breast cancer progression. That has all been debunked. And we now know that actually soy can be a really healthy plant-based protein to eat in moderation, could even be on a daily basis. We don't want people to only eat soy all day, every day, but incorporating into diet through
tofu or soy milk or edamame or miso, that's all completely fine.
And regarding the question on safe exercise or physical activity in metastatic disease, I think that's where our rehab team, myself, and our physical therapy team can add a lot of value because, again, everyone would probably agree exercise sounds good and should be something that we do, but how we do it, what strength training looks like if someone's had surgery or radiation, we want it to be tailored to an individual. And part of our clinical practice is seeing patients and evaluating patients and figuring out what type of exercise, like what type of strength training is going to be helpful to help recover from surgery or treatment, and also give patients precautions on things to avoid at the gym in their day-to-day, activities like vacuuming or laundry, or what are modifications to help you avoid things like pain, risk of falls, to better tailor that exercise prescription.
Yes, I know there's probably a lot of different opinions about this, but in the first talk, they were talking about losing weight. And, like as someone who I was overweight before I got diagnosed, and then I got diagnosed, I'm still technically overweight. What would your recommendation be about because I'm scared to lose weight because I feel like if I'm losing weight, then something's not going well with my treatment or not going well. So do you have any recommendations or advice about how to combat that or how to approach that kind of stuff?
Yeah, I think for that, working with the medical team is really important, or working with the nutrition team specifically. I think there isn't a general global target or method that we can promote or we can recommend at this point. Yeah.
And I'll just add, when we in the rehab space or exercise space, weight is one thing, but body composition is another. We really want patients to maintain or even improve their muscle mass or muscle quality. And weight can fluctuate. There's a lot of factors related to that, but your physical ability to do something matters a lot, regardless of numbers on a scale.
So this isn't so much as a question, but the physical therapists here at the Hutch are amazing. First of all, they got me back on my feet and I'm able to walk because of them. So your team is fabulous. I'm really speaking to the leadership up there at Fred Hutch. They really need to invest in better PT facilities for you guys. I mean, the room is tiny.
Oh, I
The
hear ya.
need is great. So this really needs to be something that they invest in and include physical therapy as part of the whole clinical picture, besides just when, oh, now you can't, you can't raise your arm or something, let's send you to PT. Well, let's try to avoid that. So, and I want to follow up on her comment about weight. When I started this journey almost 3 years ago, I was 80 pounds heavier than I am now. And I kept thinking my cancer's estrogen positive all the way, 1,000,000,000%. Well, I was diagnosed postmenopausal. So I'm like, where the heck's my estrogen coming from? Then I learned it comes from your fat. And I'm like, oh my God, I ate myself to death, And I started at that point a very slow and purposeful journey to I wasn't trying to lose weight, but it was, how do I eat to decrease the estrogen? How do I, stop alcohol, sugar, all of those things. And over a 3-year period of time, I'm at a very healthy weight and I'm healthier. I'm the healthiest sick person you'll ever meet. I'm healthier now than I was. So don't be afraid to get stronger and healthier in the space that you're in.
I would just, as a medical oncologist, I would just put a quick word out there to say, just because by BMI standards or body composition standards you are overweight doesn't necessarily mean that your breast cancer is your fault or that you need to lose weight as part of your breast cancer treatment. Everybody's journey is different. You're not feeding the cancer by having extra adiposity. That's not how we think this works. But Absolutely, getting healthy, getting stronger, and like altering your body composition to have more muscle mass and more ability to do things is great. I don't want to eclipse anybody. I just wanted to make that quick comment. Absolutely, yeah. And to the extent that you have agency and control, absolutely.
I have Heather, I was wondering if you could comment on intermittent fasting. And then I also had a question for Hannah. If you can talk a little bit about like, sort of what is that rehab program for metastatic patients? What does that look like? What do patients get to do at Fred Hutch? And how do you transition them to like potentially like community gyms, and what kind of support is available for that?
So good question. There's a lot of interest in intermittent fasting. And again, if you go online, there are 20,000 different definitions of intermittent fasting and a lot of, variations in quality of data that are out there. We call it time restricted eating because that's how we're thinking about it. And I've also spent a ton of time talking to the nutrition team about this. What we can advocate for and what we think that is safe is time restricted eating with no more than a 13 to 16 hour overnight fast. And so it's just prolonging the fasting time or decreasing the eating time during a regular day, and then just having a normal overnight fast that allows the body to sort of, clear and do all its metabolic things that it does, but it doesn't put anybody at risk of unintended weight loss. So again, a lot of times we're worried about muscle mass loss with time restricted eating. But it can be definitely, we think it can be a healthy thing to do between 13 and 16 hours. Again, depending on where people are. And so talking to one's medical team or the nutrition team, I think is really important.
And in terms of our kind of rehab program here, we have a growing rehab program. Myself as a physician or rehab physician, our physical therapy team, lymphedema therapy team, as well as kind of resources in the rehab space at UW. Sometimes we see patients really once or a couple times just to solidify what an exercise program would look like. We think of exercise or physical activity in two domains. One, general conditioning, and the second being targeted exercise. And general conditioning will look different for each individual depending on your physical kind of function and what your goals are. The general conditioning, we think of strength training and aerobic activity and tailoring what would be safe for that space. And when we talk about targeted exercise, that's recovery from, let's say, radiation or surgery, or targeting an area that we think is at risk for being tight, let's say from mastectomy or radiation to the chest wall or surgery on the spine, of figuring out what exercises are going to give you that bang for your buck to recover and heal in that specific area, or for neuropathy, and coming up with a pragmatic home exercise program that you're able to do. Not necessarily that has to be done in a gym or with equipment, but things that you can do at home that's really just practical. And then if individuals have certain goals like returning to a sport or returning to work, then we can pull in different resources that include like vocational counseling to tailor that exercise program for responsibilities or job-related function, as well as return to sport.
My big question is the fact that Medicare doesn't cover integrative health. And everything you're talking about is really great, except for they don't cover it. And so I remember checking into that in Olympia, and an initial visit was like $400 and some just to, just to even get in a program.
So good question. I can take that one. So here in Washington State, we're actually a unique state in the whole country. In 1994, our insurance commissioner mandated coverage by private insurers, not Medicare, for naturopathic medicine, acupuncture, massage therapy, and chiropractic care. So some of our patients here can access the services. So our integrative medicine program here, we actually do have it so that part of it is accessible to patients who have Medicare as an insurance. So we have two parts of our integrative medicine program. We have integrative medicine consults, and then we have acupuncture. And our integrative medicine consults are staffed by naturopaths, but we're also staffed by advanced practice providers, nurse practitioners, physician. We don't have a PA at this point, and a medical doctor. And so those providers are covered by Medicare. So if you're a patient here, you can schedule with those providers. And then acupuncture, some insurance plans will cover that, and some patients choose to pay for it out of pocket.
Like massage therapy is like heaven.
Yes. Vote.
Oh, I have to. You were talking about meat. I grew up on meat, potatoes, and a salad. That's what our whole life was, me growing up. But I do like a lot of fish. Does that include shellfish?
Sure, yeah, shellfish. Yes, shellfish is great.
Good.
Yeah.
Last question. I have a question for Ray. So in your 18 years of cumulative experience with metastatic patients, I was wondering in their journey, where do you feel like has been really helpful for them to have a consult with you? And I'm sure it's obviously individual, but just wondering where you've seen the benefit for the patient and maybe their caregivers in their journey.
Yeah, thanks. Anytime you feel like it. Sorry, it's not very helpful, but I speak with a lot of folks when they first get diagnosed, and I would say that the scariest time is often between diagnosis and coming up with a plan. Likewise, I guess for folks in here, you know, it can be a really scary time right before scans, and as you heard earlier, and when you have to change treatments is a really scary time too. I just had a wonderful visit with a patient who was really scared about changing treatments, and you know, a month later she's on a new treatment and she's cancer free. And it was like, it's like, yes, this is why we say, you know, what if it all works out? Like, you know, the best case or the worst case scenario can help us to feel prepared for whatever's coming, but we really never do know what, you know, the next treatment line will do for us. So any of those, you know, heightened emotion times are great to connect with spiritual health. And yeah, if I didn't say before, you know, I'm not here to give you advice, and I just collect wisdom and pass it on, but mostly just here to hold space too, and just help folks to keep those emotions moving, you know, emotion, keep the feelings moving, right? Because you all have the wisdom that you need inside. You've been living in these bodies for as long as you have and know what's best and right for yourself. And sometimes we just need somebody who cares and who can sit there for an hour and listen until we figure out what we need for ourselves. So anytime in the journey that feels appropriate. And it's non-billable service. There's no extra charges for your insurance or you as far as being a patient at Fred Hutch to utilize spiritual health and social work for supportive counseling. And just a little plug for them, you know, we both, social work and spiritual health, both provide supportive counseling. And it really is just kind of up to you who feels best for you. You can have a intro visit with either of us, you know, either of our departments, and whoever you connect with more, right? Whoever you feel comfortable with. Some people have, you know, they have a history with social work. Some people have a history with spiritual health, and you know, honor that and just go with what feels right for you. We love to be with you on the journey.
Let's give another round of applause for our speakers. Next up, we have a guest speaker who I am really, this is a special moment for me to be able to introduce my mom to you. This is Dr. Silvia Corral. She is flying in from California to speak with you guys today. She's a family physician, was diagnosed at the time that I was entering medical school, and basically how I found out about radiation oncology and ended up choosing that career. Always thinking about others, and so many ways that has shaped how I approach the world. And then, yeah, cancer was a time for caring about herself before thinking about others, and that was so unnatural. And I won't like go into too much details, but she went through her treatments and had some time that was quite difficult. And as she has improved, she now is in a position where she's had that unique experience of knowing what it's like being the provider, knowing really what it's like being the patient. And she has such a rich network of friends and connections, and she's always wanting to help new people. So she's traveled around California being sort of your personal advocate for some of her friends and friends of friends who are going through their breast cancer diagnosis. And I think she's developed this unique expertise and perspective in being with the patient and helping you as a patient have your voice be heard and what's important to say in a doctor's visit. So hope that you guys enjoy this talk, and without further ado, I'll let my mom talk.
Wow. That's quite an introduction. So I don't have to disclose any disclosures. I accept that I'm very proud of my son. And I find that I'm always learning from him. He's got an old soul, so to speak. So this topic, I want to thank the organizers for inviting me. I also want to thank the Breast Cancer Resource Center in Santa Barbara, who might be online, for giving me the position of volunteer medical advisor, because I've been able to continue being a physician, serving others through my volunteer work and as a personal medical advocate for people. Self-advocacy, finding your voice. Well, I was an advocate, very fierce. You as a doctor, you would want me because I would fight for you. But it wasn't until I got breast cancer that I found my voice for myself. So this is a very important topic because it's not an easy thing to find your voice when you're always have been caring for others. Just a quick acknowledgement. We are in the land of sacred people. I worked with Native peoples on the Navajo and Hopi Reservation, and also here in Washington State in northern Mount Vernon area. So there is a lot of thankfulness that we need to give to the Native people of Washington State for holding this space for us. So women are amazing advocates for others, but we don't really know how to be advocates for ourselves. We achieve great things when we speak up for our kids, when we speak up for our communities. So for me, the lesson was 2012. I was a few months late for my mammogram. I had been attending Benjamin's graduation. And all of a sudden, there I was, triple negative breast cancer, 20%, invasive lobular, 20%, pleomorphic cell type, less than 4%. I had a very rare breast cancer. But I got VIP treatment because I was a physician, and within a week or two, I had seen a surgeon, I had the MRI, and I even got to see a preoperative oncologist. At that time, neoadjuvant therapy, which is treatment before surgery, was just beginning. And I asked, do I need treatment before I have surgery? And I was told, no. Your biopsy is wrong. Invasive lobulars are always going to be estrogen receptor positive. Don't you worry. Well, mastectomy, pathology came back, and guess what? The oncologist was wrong. I was a triple negative breast cancer, invasive lobular, pleomorphic cell type, and a stage 3C, which is considered by Social Security disability metastatic. I was scared to death, and I received a phone call from the nurse's office saying, oh, by the way, we want you to start treatment. Here are your appointments. Not even a phone call from the oncologist or from the physician so that I could talk, so that I could ask questions. At that moment, I felt terrified. Something was wrong. I heard this inner little voice saying, no, 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 you're on the wrong path. And I took the very first step to saying, I deserve to have a physician who is going to fight for me like I have fought for my patients. And you know what I did? I fired my oncologist. Hey! And I went looking for another oncologist to be my partner. And I believe that that decision, my first step to self-advocacy, is the reason I'm here. I have had to switch oncologists, and when they look at my record, he looks at me and goes, you're still here? And I'm going, yeah. And he goes, well, whatever you're doing, keep doing it. You're a miracle. Because all of those little statistics I read to you were a death sentence in the oncology world. So self-advocacy is very important, and we as women need to learn how to take this step. So I'm going to try to share with you the definition, some of the fundamentals, a behavioral skill set. I'm going to list it. I'm not going to give the workshop that should go with it. Focus on the doctor visit, and then hopefully summarize. And as I'm doing this, I'm hoping that you can see how this term self-advocacy actually builds on so much of what has been happening here at this conference. When I heard Ray talk about spirituality, how to get there means you have to love, care, say that you deserve things. How to practice good health, good nutrition, you have to take steps. You have to advocate for yourself. So being a self-advocate is all about learning how to take these resources that are being presented to you and learn to apply them to yourself, because you're important. You deserve it. You have to make yourself number one. Self-advocacy is the ability of an individual with cancer to overcome challenges in getting their preferences, needs, and values met. Self-advocacy is portrayed as a method of addressing power and information disparities between patients, providers, and the larger medical system. But can you believe it? There are several studies that find that cancer survivors are hesitant to lead their care. They don't want to engage in health information and lead decision-making.
So why is this? Why is it that we don't want to take the step to become our own advocates? I've thought about this. I think it's because we think that we become a squeaky wheel, rude, demanding, complaining. Somehow that becoming a self-advocate, you become someone mean. But I want to tell you that is far from the truth. Self-advocacy is actually a gentle, beautiful way to take a step towards empowerment. You remain positive, you talk from your self-worth, you promote your internal strength, you learn skills in communication that help you connect with the healthcare team, you build better relationships with your healthcare team, you find ways to manage the anger that can come up as you're meeting one challenge after another. It gives you confidence to face challenges that seem insurmountable. The studies do show that if you know how to advocate for yourself, you improve the quality of your life. You turn feelings of hopelessness and helplessness into feeling hopeful and having ways to address your fears. I wanted to, before I go to this skill set, I wanted to give you an example of someone that actually had this fear of being a self-advocate. She was in our support group. I run a group for metastatic breast cancer survivors. And she was an engineer, worked in the men's field. So she was very, very intelligent. And everybody kept saying, oh, you're doing so good. She was in treatment for metastatic, her oncologist, oh, you're doing great. Keep going to work. But cancer markers kept going up little by little by little. And she was scared. She says, what am I doing wrong? And we're in the support group. We're like, why are you working? Why are you still struggling? Why are you not creating space in your life for you? And she said, well, who am I if I stop doing this? Who am I if I stop taking care of others? So with a little support group, a little bit of counseling, she filed for disability. And guess what? She's alive. Her treatment started working. She has not had a change in treatment in over 4 years. And she's the first one that'll come back and say, why did I learn how to advocate for myself sooner? So what is the behavioral skill set that comes with self-advocacy? Usually people have 4 things: information seeking skills, communication skills, problem solving skills, negotiation skills. But I've added 2 that I think are very important for cancer patients. The first is value clarification. We have to decide what it is that we want, because all of this is about achieving our goal, and each one of us is very different. Your self-advocacy could look very different than mine because you have a different goal. What kind of life do you want to live? What kind of death do you want to have? What kind of medical treatment do you want to engage in? That can't happen without value clarification. I found counseling to be critical for me. And so I encourage, as Ray said, there are counseling supportive services to get in touch with your core values. No one can take that away from you. And the last thing is I added build your team. we don't climb a mountain by ourselves, even though the backpacker was by herself climbing the mountain, you know? But most of us would consider doing that kind of dangerous to do it by ourselves. So is the cancer journey. You build your team, your Sherpas that help you carry the load up the mountain, family, friends, support group. Look outside the network, people that you've met who have maybe become experts, the cousin of so-and-so who's an expert on this. And you start building your support network so that when you go to information seeking skills, hey, you're not the internet queen, but someone else might be the internet expert, right? Or you could decide that you want to trust your doctor. Communication skills. Hey, are you good at asking questions? Learn how to practice with people. I want to ask my doctor this. Well, if you go in and ask it with, I've just read 5 articles and it says that this and this and this and this is the right thing to do. Why aren't you doing it? That is not going to be heard. That doctor has heard the anger in your voice, has suddenly been challenged, and he's human, she's human. We back off, we become defensive. So you come in and say, Doctor, I'm curious. I've just read 5 articles, and is this something that would apply for me? Because I've been thinking that it might be something that we should be doing. What do you think? Same question, different approach. But it's those kinds of communication skills that you learn when you become more of your own self-advocate. Problem-solving skills, you get information with your network, family, friends. You learn to have plan A, plan B, plan C. And negotiation. Negotiation, there is no decision, there is no treatment that is a black and white. I've known people that take 4 weeks off treatment because something's much more important. And they negotiate that with their care team. So let's talk about, well, I want to give you another example. Do we have time? An example of how I saw one of a patient use those last behavioral skills. Her name is Nina. She was an older woman, very quiet. You might even think her somewhat passive. She went to church and she had a big church congregation helping her. So she had lists for who would help her with groceries, who would help her with transportation, who she would call if she needed this or she needed that. When she walked in to her doctor's, she didn't go in prepared with questions. She was the person that chose, I'm going to trust my doctor because I'm going to ask God in her world, her faith, to give my doctor, my whatever, in charge of taking care of me. And I'm going to trust my doctor to make my best decision. Believe me, for me, that was a very hard thing to accept, but it was informed. She was doing it totally conscious. She knew she had other options. It was her decision that was how she was going to take information. So when her metastatic breast cancer stopped responding to treatment, she could have chosen a clinical trial, but she didn't because she did have a bottom line in the negotiation. She was not going to use all the financial resources and leave her husband in a state of poverty. That was most important. So the community, actually, all the support that she had gathered in her team was able to find her hospice in a facility. And 2 weeks into her hospice care, she turns to me and says, Silvia, I'm not dying. What's wrong? And I said, well, I guess you're supposed to be living. What are you supposed to be doing? And she said, oh. And she wrote a play for her church. She organized the celebration of life and chose all her songs and words. She did a bunch of gifts and letters, and she used the next 6 weeks to do things in her life that she had not been able to do while at home, because she had all of this assistance from hospice to keep her going. And she died the most beautiful death. That was the result of her learning how to be an advocate. It wasn't the way I would have advocated, but it was her advocacy. Her information, her communication, her preferences, her bottom line negotiation. The doctor visit. Okay, doctors. Doctors see 15 to 25 patients a day, and we're supposed to analyze labs, know what's been going on, go from one place to the other and be cheerful and be there with you, okay? You're the patient, you only see one doctor that day, and that visit is like gold for you. So who do you think needs to be in charge of that visit? How many people want the doctor in charge of that visit? No, you are the CEO of the physician visit, okay? So planning for it, your agenda, your goal. I always tell people, write down, by the end of this visit, I want to blank. By the end of this visit, I will have blank. So you can fill in those things. You know what you're going in for. Write down and make lists. Don't leave it to your head. Don't even leave it on your cell phone, okay? Because you get nervous, and you have to look down, and your doctor can't take that cell phone with them. You can leave them with a list. You can leave them with those pieces of paper so that they don't forget what you talked to him or her about. I think they should bring someone with you, a buddy, who can stand up for you, and listen with you, and write things down. Bring copies of reports if you have been somewhere else. Do not assume that the medical care systems will communicate with each other. The computers make all sorts of mistakes and shut down. So always have copies of reports from other places. And before you leave that doctor's office, you get copies of reports. You have a copy of every PET scan, every consultation, and have your own folder. It is, I can't tell you how important that is. When I go to work with a person as a medical advocate, I go, can you show me your folder? I don't have one. Well, what is pathology of your tumor? I don't know. I don't care if you don't know, but I can't help you if you don't show me the piece of paper that will let me know so I can help you. Then the last thing, there's two things. At the end of the visit, ask for referrals or resources that might be helpful to you. People have talked about them already: nutritionists, community groups, physical therapy, support groups, nurse navigators. Something that has not been mentioned, but I think is very important for anyone with metastatic breast cancer, it's palliative care referral. I don't know if Fred Hutchinson has one yet, but it's another oncology aspect that helps manage side effects, and just another person on your team. And ask for how to keep in touch. What's the best way to reach them between this visit and the next visit? When you ask that question, all of a sudden things come up like, oh, I'm going to be on vacation, oh, next visit, you'll have, between now and then, you need to talk to my nurse practitioner. You know, oh, no, you know, you're on this new treatment, you're right, let me give you my cell phone. You know, you don't know what can be offered to you about access unless you ask for it. So I'm getting towards the end here. I was so frightened when first diagnosed, but I couldn't stand feeling helpless. So I decided I had to actively participate in the treatment I received. Doctors tend to treat symptoms. I insisted that my doctor treat me, the patient, the person. I insisted on a dialogue. When treatment was determined, I wanted to know the purpose, the side effects, and the alternatives. Then I researched everything. I don't know if it can be measured, but I know that it helped my recovery, and I know it's the reason that I'm here, a 12-year survivor and thriver. A good resource is the National Coalition for Cancer Survivorship, Self-Advocacy, a Cancer Handbook. And just remember, you're the CEO. Self-advocacy improves quality of life and outcome, and it improves your relationships. Thank you. Thank you very, very much.
Thank you so much. We are a little short on time, so we only
So we're gonna, I don't think there's any questions, right? I have met several of you, and I have been so impressed by the courage of all of you. Several of you I just think are heroes being here. I think this is wonderful. I hope that Fred Hutchinson does this every year. And I wanted to cry because you are all fantastic. You're all advocates. You're here.
I wish we had more time for questions, but I mean, we're going to do the next session. If you have questions related to Dr. Corral's talk or to ours, we can take them both at that time. So come on up, Dr. Hunter. We are going to do an abbreviated version of how to approach and consider a clinical trial. Repeat the land acknowledgement. So thank you to the Coast Salish peoples of this land, all the tribes and clans of Duwamish, Rialis, Miramish, Tulalip, and Muckleshoot nations. And the reason is pretty simple. Actually, I go over this a lot of business. It will seem really confusing to talk about all these studies. It can also seem pretty confusing. So I think it's a pretty human experience that just research is confusing. But I've broken it up into a way where I think anyone can understand what's going on. And so hopefully by the end of this, you'll be able to see a study and kind of be able to like tell a friend like, hey, what's this all about? So first, for patients and caregivers here, any clinical trial that you see is basically answering one of two questions. It's not that complicated. We're interested in, okay, can we make outcomes better? And I might be asking that question if I'm trying to treat something where we think that the outcomes aren't good enough yet. There are a couple ways that I could try to make outcomes better. Some of these are intuitive, like, well, what if I add some more something? What if I add more dose? What if I add a new chemotherapy agent? Or what if I add immunotherapy? What if I add radiation? Another way that we sometimes try to make stuff better is we play around with the order. Oh, what if we do chemotherapy before surgery instead of afterwards? Or what if I do radiation first and then surgery? What if I do surgery first and then chemotherapy? So there's like, you know, you can play around with these different orders. And a lot of trials are doing this. Another one is switching the systemic therapy agent. Okay, instead of using this thing, what if we use this thing? The other kind of question that a clinical trial may be asking is, can we reduce harm with this treatment? And I might choose this question if it's something where like, whoa, the outcomes are already really good in terms of survival, like 99% local control. Maybe we don't need to be as aggressive and we can still maintain that really excellent cancer outcome. And ways that we can reduce harm is like, okay, what if I take away a treatment? What if I don't add the systemic therapy? Or what if we skip radiation? Or what if we skip surgery? Another could be like, okay, what if we use less dose? We'll still give radiation, but maybe let's do 1 week instead of 3 weeks, instead of 5 weeks. Same with chemotherapy. Even with surgery, what if I do a less invasive surgery? And then lastly is, okay, what if I give the same thing, but just give it like a slightly different way? What if I allow for like more time in between sessions? Or what if I just divide the sessions into light sessions and do those like twice a day? So there's ways we can play around with this. But yeah, that's like every major cancer study is just answering one of these two questions. And the one exception might be phase 1 clinical trials, where these are experimental and they're not at the point where it can answer a question besides, is this safe?
Just adding a quick comment to this. I think this is the right outline for, can we improve outcomes and can we reduce harm? That's kind of how we think about things. And then sort of tertiary, are there new drugs that sound like good ideas that might be safe to give? And then later on, we can decide these other two questions in relation to those new drugs. In the metastatic setting, at least most folks in the metastatic setting are on some kind of systemic therapy. And so many of the clinical trials that we're looking at are looking at sequencing. What happens if we give, someone in the audience a while ago asked about Enhertu. Should we give Enhertu with a related drug right next to it, or do we need to spread those drugs out for better outcomes? So sequencing trials, new drugs, and whether they're helpful in a different kind or a different subtype of breast cancer, metastatic breast cancer. But then I think a lot of folks are struggling with the side effects of the therapy that we give them. And so there's a lot of questions out there looking at reducing harm in the metastatic population. Are these doses that we're giving, is the maximum tolerated dose, which is what we normally give to people, because it's easier to find out how much can you give a person than it is to find out how much is good for a person. And so we're looking at dose reduction studies. You know, what happens if we only give half the dose? Is that as effective? Can people get benefit from that and get less toxicity?
Yeah, great points, Dr. Hunter. So thinking about phase 2 and phase 3 clinical trials, and these are probably the most common kinds of trials that you may encounter. I like to use this analogy that phase 2 is kind of like, who's the next up and coming champion? You know, Rocky's training. So each of these phase 2 studies is sort of introducing a new player to the field. Like, okay, there's been some reports that, you know, maybe doing this, I'll just use radiation as an example, like doing a high single fraction of radiation to the breast before surgery for early stage breast cancer. We've read some reports that works well in Europe. I know some people are doing it in the US. Let's make a formal study around it and see, can we get some high quality data on this? And so as you can imagine, there's lots of players in the phase 2 space. Everyone wants to be the new boxing champion. But to make it to phase 3, this is where, okay, Rocky, here we go. You've done so well in the rounds leading up to this, but now we're going to put you up against the big boss. We're going to put you up against the standard of care. And so this is a boxing match where whoever wins is going to become the new standard of care. I mean, any drug company who has their drug is going to be really vested to try to make theirs seem like the best. So there's definitely some caveats that go into interpreting a phase 3 study. And sometimes there are nice dialogues. You may have explored other conferences and events where they talk about the results of studies. Sometimes it's a little murky, like what does this mean? But the general principle was like the goal was to figure out what's the best thing to give patients in this situation now. And for you, we wanted to talk about the considerations of being on a clinical trial. Maybe you are currently facing this decision, or for our virtual members too. Or maybe it's something that you've thought about and maybe it's come up in conversations, or maybe it's going to come up. There are some considerations, definitely some benefits. Whenever we have a clinical trial, like we need to have the data on the patient for all these different timestamps. So you have a lot of eyes on you. People are going to ask, how tired are you feeling? Do you have this symptom? Do you have this symptom? Do you have this symptom? These clinic visits will be very thorough. And we try not to let anything slip through the cracks in terms of how you're feeling. One of the other considerations is like it's unknown. Just because it's a clinical trial doesn't mean like I'm gonna have the best outcomes. There is some rest assurance if you're on a clinical trial, and if it's a phase 3 trial, like you're going with something that's rocky power. It's been pretty good as leading up to this, and I think most times when we do a phase 3 clinical trial, we're hoping that the new boxer we're putting in the ring is going to be the winner. Obviously, when you are participating in a study, well, actually maybe not obviously, but the benefit is beyond just your life, but you could be helping advance science and helping future patients. And it's probably off the backbones of many patients who have come before you, but you were able to get the high quality care that you received leading up to today. And then another thing for a clinical trial is eligibility criteria. And whatever happens, we will continue to do what is in your best interest. But there may be some things where you have a decision to do something that might make you ineligible for the trial. And maybe that's worth it. So maintaining eligibility criteria will be conversations that you'll have with your oncologist. And certainly you have to be eligible in the beginning to start. And there may be some eligibility criteria like no smoking, just to give an example. And then when should I consider a phase 1 clinical trial, or should I? And usually if it's come to you being offered a phase 1 trial, you probably have worked with an oncologist for a while, and you've probably established some trust and rapport with that person, and hopefully you have enough of a relationship with them to talk about the considerations. But if you're just coming out of the gates like, oh, I read about this phase 1 clinical trial, I have this new diagnosis, can we please do it? Usually hold off. Phase 1 trials are more like after we've tried the options that have more robust data to support their use.
High school boxing. Just trying to extend your metaphor.
Yes, that's right.
Can I add just a few things to that quickly? I do think that it's really important to understand, it sounds super technical to be thinking about phase 2 versus phase 3 clinical trials, but I think those are important considerations because patients often do have concerns about, am I just going to be a guinea pig? Is this just some experimental treatment? And so by the time that something has reached a phase 2 and certainly a phase 3 clinical trial, this is something that a lot of people have a lot of hope in. there is no guarantee. And so the uncertainty that people face in terms of whether this actually is clinically beneficial or not is something that patients and providers have to struggle with when offering a clinical trial. But at least you're talking about something that's been vetted through safety and other kinds of gates. It's not just something that came straight out of, a mouse model. I mean, if you were a mouse with breast cancer, the news is good for you. We've cured a lot of breast cancer in mice. But
Okay, let's talk about the two ways that you may encounter a clinical trial. One is an oncologist presents it to you. I don't even need to do an example. Okay. Number two is you do some searching and you discover one, and then you want to share it with your oncologist. And these are, I think these are the only two ways that a clinical trial can come up in your doctor visit. So we will do a very quick example scenarios where Dr. Hunter will be Dr. Hunter and Dr. Lee will be Dr. Lee, the patient.
thank you. We're here all week. We are professional actors. And we also want to, sorry, I'm not used to talking into a mic. We also want to let you know that we're not talking about any specific clinical trials today offered by Fred Hutch. All of the clinical trials that are offered by Fred Hutch on metastatic breast cancer are listed at the Fred Hutch website, and they're accessible to you. If you have any questions about things that you might or might not be eligible for, feel free to reach out to us, reach out to your oncologist to ask about eligibility. But this is more about kind of general considerations as you think about entering or not entering a clinical trial. Please forgive us for our acting abilities.
Hey, Dr. Hunter, it's nice to see you.
Hi, Ben.
So what are we going to talk about today during my visit?
So today I wanted to mention to you, I know that we talked on the phone about how the scans that you recently had looked like your metastatic breast cancer is developing resistance to the current therapies. And we talked about a couple of options that are available to you. As you know, that there's lots and lots of treatments for metastatic breast cancer. And we discussed on the phone a few of those potential treatments. But another option has come to my attention, and it's called a clinical trial. It's a phase 3 clinical trial that we just opened that I think that you'd be eligible for.
Okay, well, I've heard of that, but I don't really want to be an experiment.
So tell me about some of your concerns about that.
I feel like, I don't know, will you be taking advantage of me? Am I going to be a guinea pig?
Yeah, so I think that we've talked about that, breaking my role, breaking character. We've talked about that a little bit, but this actually is a phase 3 clinical trial. So what it means is that we've looked at a lot of safety data for this medication. It's an oral medication that we'd be providing, and it would be in conjunction with a medication that's already a normal treatment for your breast cancer. So it's not just that you'd be getting a treatment that's new, it's actually that you'd be getting standard treatment plus this other medication.
Okay,
And the medication has already been shown to be safe.
okay. What's the goal of this?
The
Is it
goal-
going to cure me?
Unfortunately, as we've talked about, there's no known cure for metastatic breast cancer. This clinical trial, the goal of this clinical trial is the same goal that we've had for all of the treatments that we've had to date, which is to try to extend your life and walk that fine balance between providing you with a treatment that's strong enough to control your cancer for as long as possible, but also gentle enough to allow you to have an acceptable quality of life and live your life, with as much joy and meaning as possible.
Well, that sounds pretty nice.
Always sounds good.
Well, I mean, surely this will cost me something to be on it.
Participation in a clinical trial should not cost you any money. Certainly, if you are encountering additional costs, you should talk with us about that. But your participation in a clinical trial is a partnership between the institution who has an interest in doing medical research and finding new therapies for metastatic disease. But it's also your generosity and the generosity of patients like you that are contributing, are accepting a degree of uncertainty in their treatment and hope in order to move the research forward. And so there shouldn't be any additional compensation. We're not able to pay you to be part of the clinical trial, but you also should not be losing money to be part of this. Should be an equal exchange.
Okay. So I'm open to the idea, but like, what if I don't like it? I don't want to break the rules, but like, what if the drug doesn't sit well with me? How long do I have to be on it?
There are no rules, basically, as long as you are feeling good on this medication in the same way that other treatments work. As long as you're feeling good on the medication and as long as it appears to be working, we do the scans, we do the monitoring, and it seems to be helping you, you would remain on that medication. If you don't like it for any particular reason, either the medication or the actual protocols of the trial, the number of visits that you have to do, if there's anything about the clinical trial that's not sitting well with you, you are welcome to withdraw at any time. It doesn't change our therapeutic relationship, doesn't change any way that we would treat you. We would just find the next best thing and go with that. So this is always your choice, and it is always out of your own, you have to choose the right path for you. And so it's always out of your own sense of what's best for you. Also, if you and I were to decide that this drug is too toxic, or for any reason we wanted to stop therapy, we can always do that together.
Okay, and would you still be my oncologist?
Still your doctor.
Yay. Okay, hopefully that answered some questions. We're going to go on to the next one. So now the patient has taken some initiative, and I am going to ask Dr. Hunter what she thinks about this new study I found. Good afternoon, Dr. Hunter.
Hi, Ben. How are you doing today?
I'm feeling pretty well. I did want to talk about something important. I did some research and I found a clinical trial that I was wondering if maybe I could go on it. It's called the NXB 4263 Turbo trial.
Yes, I know it well.
And yeah, it seemed really good. It had like 90% 5-year survival rates, and I would like to be on it.
Yeah, so I'm looking at the trial. What was your understanding of what the goal of the trial was? Why do you think that you might be a good candidate for this?
Well, I mean, I'm not the expert, but I see some high numbers and it makes me hopeful. And, I have to be CEO of my own visit.
Darn it, he's advocating for himself. So I really have to applaud you for taking the initiative and really trying to explore options for your therapy. I'm pleased to see that you're interested in clinical trials. I think that a clinical trial in many, many cases is a great option. And certainly the fact that you're expressing interest in clinical trials is great for me to hear. It means that I'm going to keep my eyes particularly peeled for good fits for you. A couple of things that I'm seeing with this particular clinical trial. First of all, it appears to be offered in Denmark only. And so that unfortunately will probably mean that you would need to move to Copenhagen and become a citizen and get their insurance. So I'm not sure if that's feasible for you. It's something that we could look into. However, there are some other obstacles that I foresee in you entering this clinical trial. It does seem to be for early stage patients that are HER2 positive. And so those qualifications, those eligibility criteria are not criteria that you would meet. The third thing, though, is that it's actually a phase 1 clinical trial, which I'm not sure that in terms of where you're at in your therapy and in your journey, that phase 1 is really an appropriate step to take. Phase 1 is oftentimes more focused on safety. And I think right now we have some really effective, really safe treatments that we can offer you without trying to kind of roll the dice with a trial that's focused on a very experimental agent. So for those reasons, I would say, let's maybe put that one to the side for now, but I would really encourage you to continue to look at clinical trials and bring them to me, and we can certainly assess them together.
Okay. I mean, yeah, my brother was telling me like, oh, Ben, like, you don't qualify for this. It doesn't meet the eligibility criteria. I guess he was right. I wasn't exactly sure what that meant. Sorry to waste your time.
You didn't waste my time. My goodness. We will certainly keep an eye out for clinical trials that you could be eligible for. You don't apologize to your financial advisor for not understanding what a mutual fund is. You shouldn't apologize to me for not understanding what eligibility criteria are for a clinical trial.
Okay, and then one more question, Dr. Hunter. I mean,
Tell your brother to
I
mind his own business.
um, sometimes I just have trouble concentrating, just feeling like maybe there's more of it I should be doing. I know the last scan showed the disease was stable, but like I feel like there's more out there, and should I be searching through like all the different registries, and maybe there's something better that we could be doing right now?
So forgive my unkind words about your brother. I'm sure that he's just acting in your best interest. But in terms of those clinical trials out there, I know that it can feel very, very overwhelming. There are so many clinical trials that are being offered. It's so difficult to sift through some of those sites like the National Cancer Institute and all the different sites where you're looking through clinical trials and trying to figure out whether you're eligible or not. I think that the actual clinical trials that are realistically available to you is a much smaller subset of those trials because the geographic limitations of clinical trials, like you actually, in many times with a clinical trial, you actually have to be geographically located very close to where that trial is open and taking place. And so if you're not independently wealthy and can just, pick up and move to Houston on a dime and then move to Boston on a dime, those clinical trials are something to watch and something to keep track of, but maybe not something to participate in. So realistically, I think let's start at home. Let's start here in Seattle, looking at the clinical trials that are here available here at the Hutch, available maybe at Swedish, and then there might be clinical trials that are available in Oregon that might be more realistic. But looking in that general geographic area and keeping an eye on the research, knowing what, asking me questions about what's coming down the pike, but knowing also that you and I will continue to be a team and will continue to look for the right clinical trials. As we move forward with your treatment and we begin to trust each other more, you can come to me with whatever questions that you have, and we can make sure that we're taking a look at all of the clinical trials that you might be eligible for.
Well, thank you, Dr. Hunter. I'm so glad you're my medical oncologist. So there is a website.
Yes.
And there's no QR code, but I think we'll be sending you all information with several Fred Hutch specific links. We also had some amazing other resources that have been shared throughout this conference and this time together. And we may be able to curate a list of that for everyone. But at least here, there's a lot of different clinical trials at the Hutch. I mean, it doesn't mean that there is one right now that you should be doing, but you can filter by breast cancer. You could do other filters, and maybe you have other friends who are also going through a hard time. So this tool exists.
And I can say, just sort of insider knowledge, I see you and I see you. I can say that our research group, COVID was tough on us and tough on everybody, but our research group has really revived and we have a wonderful research manager. We've opened a lot of new clinical trials recently and a good number of them are in the metastatic space. And so I think that there's been a pause, it's been tough, but we're kind of getting back up and running. And so that machine's wheels are rolling again.
And I will include the clinical trials link in the post-event email that goes out to you all, so you all will have access to that.
And then, by the way, this is Ritu, who has been
my
a
gosh.
champion behind the background of organizing this conference.
So Ben and I could not, none of us could have, this whole event could not have taken place without the wonderful leadership and organization of Ritu and then of Alana Culbertson and also Justin Demars. Everyone has been incredibly receptive. Am I missing anybody? Meredith, of course. So all of the group, the planning group has been incredibly organized and receptive, and it's just been such a fun group to work with. And so, yeah, thank you so much. And we would love to have a round of applause for those folks.
So in conclusion, y'all are experts now at clinical trials. They're all trying to answer one of two questions. Can we improve outcomes if they're not good enough yet? Or can we reduce harms if we think outcomes are already pretty good? And then we talked about the two ways that you might encounter. Both are valid. You know, one is your doctor brings up to you, don't be scared. They're trying to advocate for you. The other is you did some research on your own and don't feel shy to bring that up. It should be an open conversation. Phase 2 is exploring promising candidates. Phase 3 is an attempt to dethrone the current standard of care. Eligibility criteria is important in your search and recognize when different types of clinical trials might be appropriate with your doctor. So that concludes this session, and we're also going to take a couple questions.
Gosh, I already pointed to you up there. Well, can you wait for the mic? I just want to make sure our folks online are hearing everything.
Is there ever any compensation from pharmaceutical companies if, for instance, you don't live near Fred Hutch, but you are eligible for a clinical trial?
Yeah.
And they have to, you know, move here and live for 2 weeks or 6 months or something?
2 weeks is different from 6 months.
Yes.
It varies. So basically, oftentimes if the trial is sponsored by a pharmaceutical company, sponsored by industry, they will often provide reimbursement for travel. Not always. It really varies from trial to trial. Generally, clinical trials won't pay for you to, you know, live in the area for 6 months, but sometimes if it's like a small intervention, occasionally they'll reimburse you for travel. It just really varies trial by trial. And then you I think were next.
Oh. Well, I just wanted to clarify, in the stage 3 clinical trial, it's the standard, the king, the current is put against the new guy. And when you enter the trial, you don't know which one you're going to get. So you're going to either get the king, the standard, or the new guy. Yes, but my other thing was there are online clinical trials for people with metastatic breast cancer that are offered by like Susan B. Komen or the Metastatic Breast Cancer Alliance. So if you get on their emails, and these are a different kind of clinical trials that can be done usually remotely with interviews and things like that. And that kind of information helps gather information that can be used for advocacy and their work.
Yeah, those kinds of clinical trials, I'm sorry, just quickly, those kinds of clinical trials, there are clinical trials where you can participate. They're called non-interventional clinical trials, and some of those are interview-based, they're surveys. They're also non-interventional trials where you can donate your DNA or your blood. So everything that we talked about is more about interventional trials and not so much about non-interventional. In terms of whether you get the placebo or the actual You get it, right. You get the standard of care. Usually with these phase 3 clinical trials, you either get the standard of care or fairly commonly, I mean, it really depends on the design, but it's fairly common to get the standard of care plus a placebo versus the standard of care plus a new drug. So either way, you're getting the standard of care. If there's a standard at all, then it would not be ethical for us to offer a standard versus something we're really not sure about.
I don't know what the rest of the format is, but there are a lot of comments and questions online.
Yeah.
So,
You're so nice.
so are you guys planning on having a panel for clinical trials or no? Okay.
We're doing that.
Okay.
Come on.
All right. So one post is about basically what is the patient cost in terms of not just dollars, but tests, interval treatment, infusion, and then what do they need to do and how does that really impact them when they participate in clinical trials? Who pays for side effect management?
I think this is a really good opportunity for you to join us because Dr. Vinayak is also participating in our clinical trial panel. Yes, you.
Richie,
So-
do you want to maybe talk about the comments and questions then at some point?
Sorry, I didn't mean to
No. It's
to
good.
derail you, but I think it's more important for people to hear your perspective. So thinking about costs, so Dr. Vinayak, our wonderful speaker from earlier, has also recently participated in a clinical trial. And so maybe in terms of, do you want to respond to those questions? I mean, yeah. You're putting on your oncologist hat.
And patient hat, fused hat. So yeah, I think that's a great question. I can just talk a little bit about my experience on a clinical trial that I have just come off of. And then I can address maybe some of those comments. So I was just on a clinical trial at Stanford in California. So I live in Seattle. That did require travel. I, over the summer after my progression of cancer, traveled a bit and got some second opinions, and Stanford was one of the places that I went to. I enrolled on a clinical trial that I felt would be the best next treatment for me. In terms of the cost, we're not talking about money, but that too, I did a lot of traveling. It required pretty intense travel for the first 2 months, and I actually was only on the trial for those first 2 months. So I got to do the most intense part of the study. I had to travel to California every 2 weeks. And while I was there, it was basically a whole day of things that I needed to do. So my day would start like close to 7:30 for the first blood work. Then I would see the doctor. Then I would have an additional blood work, an EKG. And then I had to wait 4 hours to do additional blood work and EKG. So it was a full day of commitment. I did not do so hot on the clinical trial in terms of my side effects. I had a lot of them, which made traveling challenging. This is the first time I traveled for a study. This was my first experience on a clinical trial. And given that I write clinical trials for a living, it really made me question, hey, are all these tests really necessary? Do we really need these like repeat EKGs and 3 blood draws in one day? There was one day I had 7 pokes in my arm because I had to go to the ER or some EKG change that turned out to be fine. But my day that day started at 7:30 and I got home at 2 a.m. So there is a cost. I think that's time and energy. Luckily, I went to a place, my parents live in California, so that's why I chose to be at Stanford, because I did have a home to come to, and my parents have been incredibly supportive through this process, and I've gotten to, you know, spend some time with them, so that's been really good. But it was challenging, and I think that ER visit made me really rethink about where I would go for a clinical trial if I had to do this again. And I think being far away from home with no family, really no support system, that would be very challenging. And I may not consider doing that. Would I participate in a clinical trial again? In a heartbeat, just because it gave me an option, even though it was really tough on my body, but it gave me an option that's not standard of care, and that was one more thing that I could get and could see if it works for me or not. So that's sort of my experience in a nutshell.
Hello. Okay, thinking backwards here, I know we're all each on our individual, basically, plans that were given based on clinical studies of these drugs. So I'm wondering how you explain the steps of the clinical studies and the phases that goes through. Are those standard, and have they been standard for many years? I myself was on the standard of care that was the Cleopatra study, which is 12 years old. So I'm wondering if they ever revisit ones, or do they actually, for everyone, do they see if half the drug is effective? Do they see, you know, this and that, or are those applied to each study the same way?
Yeah, so you're on the Cleopatra study, which is a phase 3 study for others. That obviously that study resulted in a successful outcome that led to approval of a regimen for HER2 positive metastatic breast cancer, and it changed our standard of care. Once the drugs are approved, or a concoction of drugs are approved for a certain disease, there is what's called sort of a phase 4 or post-marketing surveillance of those drugs in terms of safety and toxicity and all of that. But we don't revisit the outcomes per se. You know, once a study is declared successful and it's approved by the FDA in terms of the drugs and they become our standard of care, then everybody across the nation is using them. But there is a post-marketing surveillance by the FDA for safety, not particularly outcomes anymore. Does that answer your question? Yes, we try to basically adopt the same approach that was conducted in the context of the clinical trial in terms of doses and how the patients are monitored in terms of blood work or EKG or, you know, heart test requirement, any of those things that were done in the clinical trial, we adopt that approach for standard of care as well.
I think one thing that is currently happening in the clinical trial research publications is they're going back to a lot of these older studies, the Cleopatra, the Natalie, the I Spy, and looking at the data that is from those old trials and trying to see how they can compare them to each other, because they're all slightly different, to help the oncologists decide, you know, which of the drugs do I give first, second, or third, since there's so many drugs coming about. I'm talking because I just did a presentation on clinical trials. And the other thing about clinical trials, it's really important to try to get people of color engaged in clinical trials. Most of them have been white women. And so representation of people of color is lacking, and our genetics and our outcomes can be very different from what is currently being published. So that's one of the other big pushes right now in clinical trial recruitment.
Well, I just did my part. Okay, I just have a,
Let me come up to get you a microphone and we have her next.
Okay, so you mentioned kind of a stage 4. If one is.
phase 4,
Yeah, okay.
just so that we can,
Yeah, thank you. If one is suffering some side effects that aren't common, who is responsible for reporting them? Is the oncologist going to report those to the CDC or the drug company? Is it my responsibility?
your oncologist can report them.
Okay.
You have enough.
Some studies will have patient-reported outcomes, and this is like very interesting. Like if you ask a doctor what were the side effects, they might say, "Oh, there wasn't any side effects. Patient is great." And if you ask the patient, they'd be like, "Well, I noticed this and this." And so PROs or patient-reported outcomes are kind of like a hot topic right now. It's increasingly important to get that. Oh yeah.
You said you were on your trial for 2 months. Was that the length of the trial, or did your side effects keep you from continuing the trial?
I progressed on the trial. My cancer progressed on the trial. I'm still here. But yes, that was the reason I came off of the study. Yeah.
What was
Yes, the data is valid and valuable, and my contribution for those 2 months is absolutely valuable, I hope.
I'm gonna just jump in. Would you mind telling us, like, what was the trial? Like, they were gonna do this, or was a drug to do that, or what was the actual topic of the trial?
Sure, it was a phase 2 clinical trial. So the phase 1 had been completed, which means there was safety data for the combination of drugs already assessed. So I was on the phase 2 portion where they were looking at one of the approved CDK4/6 inhibitors for hormone receptor positive breast cancer, and had combined it with a newer generation estrogen receptor degrader, similar to fulvestrant, but it's a newer generation oral drug. And that's the trial that I was on. And I got both the drugs. It was not randomized. So I got standard of care plus this new investigational agent, and that's what they were studying. I do want to address, I don't know, a comment that I think it's pretty valuable to talk about that was online, is sort of the timing of when patients should be offered trials. I can respond to that with my fused hat, and then I would definitely want Dr. Lee and Hunter to weigh in to see, when they offer trials. But I obviously feel very strongly about clinical research and trials. And as an oncologist and a patient, I think all metastatic breast cancer patients at diagnosis and at every progression should be offered clinical trials. There is, because I've been doing clinical trials for close to 15 years at this point, there are a lot of myths and misconceptions about clinical trials out there. One of them is, well, if I'm going on a clinical trial, that means you don't really have any other options for me. If you're going on a clinical trial as your 5th, 6th, or much later treatment, or you're too sick to be even considering clinical trial, it's too late. So clinical trials, if you would like to consider them, they're 100% voluntary. You can go on it, come off of it, of your choosing at any point. I offer all my patients clinical trials if there are any available or used to offer. upfront at diagnosis and at every point when there's cancer progression, whether we're looking at Fred Hutch clinical trials or local trials, I mean, or even California or other place trials, if the patients choose to travel to them, it is all about increasing the options if it makes sense, medically, obviously in pretty detailed discussion with your oncologist, as you just heard in role playing, if it makes sense. At least that's my belief and my practice as an oncologist.
I would totally endorse everything that Dr. Vinayak just said. I would just add two quick things. One is to really emphasize the point that you were making, that this is not a last ditch, clinical trials doesn't mean that there's no other options for you. In fact, in an ideal world, we would have clinical trials ready for you at every point of progression. Oftentimes clinical trials are designed that you recall that Dr. Lee was saying, some of this is trying to figure out what order of therapy that that we should give certain therapies in. And so a lot of times these clinical trials have very specific eligibility criteria that you can have had this and that therapy, but not this other therapy. And you can only have had one previous therapy. So they're very specific. They're not saying the patient has to have exhausted all other options. I mean, oftentimes they're very specific about what you can and cannot have quote unquote seen, what you can and cannot have experienced as treatments. So ideally, we would have a lineup for every subtype of breast cancer, metastatic breast cancer, that, you have HER2 positive metastatic breast cancer, and it is, you have this or that treated or untreated brain tumor, and we can offer you this, set of clinical trials. And once you're done with that, we can offer you the next set. So I think that that's important to understand, that this is an opportunity, totally voluntary, but it is an opportunity to get another option for therapy in there that's not standard. It's also, I wanted to quickly mention, because you described a clinical trial, Shweta, where the abemaciclib was offered plus or minus a medication. One of the That's right, plus a medication. One of the questions in the chat was, if the clinical trial offers standard of care either way, how can you tell if there's an advantage to what you're offering? Like if you're offering standard of care plus something, or standard of care plus a placebo, or plus nothing, how do you tell what the drug is doing if you're already offering this other thing? So if you just think about it, the standard of care is kind of the baseline. Everybody's getting the baseline. And so if the group of people who are getting the baseline plus the new medication do better than the people who are just getting the baseline, then we think that that medication is benefiting them in some way. There's always, and I think this is partly what the person in the chat was referring to, there's always some question about like combining those two medications. Is there some kind of confounding issue in combining them? That's always sort of a risk, but presumably you're establishing a baseline with everybody getting the standard, and then some of that group getting standard plus something that seems like a good idea.
There was, no, I was just going to say, there was a question on chat where if you feel comfortable, if you want to raise your hand, if you participated in a clinical trial, somebody wanted to do a survey.
Just how many people in the room have participated, if you feel comfortable sharing?
Okay, it looks like there's maybe one out of every 4.
4 or 5, yeah.
1 out of every 5. Yeah, thank you for your
Thank you.
participation.
We want that to be 100% if you want to.
I can't help myself while y'all are here, and I just want to share with you whatever wisdom I can. There's something that's very confusing about the clinical trial landscape. I talked about, like, you have the reigning champion versus next Rocky. But what happens is it takes a couple years to design a clinical trial. So this boxing match has been anticipated for like 3 years. In the meantime, there are probably some other researchers who also had an idea, well, I'm going to arrange my boxing match. So there's a totally separate thing. And so now you have these 2 different clinical trials, which are kind of studying the same setting. What's the best thing for a triple negative metastatic breast cancer patient? And then those trials will sort of be on uncoordinated timelines. And then maybe one of them will result in like, oh, this is the new standard of care now, like eat grapes. But then the next one reports and it's like, oh, cherries was better than oranges. And so now it's kind of confusing. Well, like this one said grapes is the best, but this one says cherries is the best. But we haven't compared grapes versus cherries. So what do we do? And this is happening like across all sorts of situations. So keep that in mind if you're an oncologist. If it's not perfectly clear what's the best thing to do, it's not a perfectly clear landscape.
Can you tell me where we are or what is happening with the breast cancer vaccine?
Well, we have a representative from the Vaccine Institute here to share that with us.
It's a targeted question, isn't it? Okay, I can tell you it's not ready for approval yet, but we are working towards that. There are 2 breast cancer related vaccines that have been through the phase 1 studies already. One phase 1 study was published last year. It's a HER2 targeted breast cancer vaccine that has 10 years worth of outcome data that's been published and showed really good outcomes. We are moving forward with, additional studies in that space. The studies that I'm working on are all really in triple negative breast cancer, more in continuing with my work from a prior life. And we're designing clinical trials with a vaccine called StemVac, which targets cancer stem cells and kind of gets at some therapy resistance and also in metastatic breast cancer. So we actually just got funding for 2 clinical trials that we're currently designing. One is going to be for PD-L1 negative metastatic triple negative breast cancer. That's going to be a phase 2 study. I'm super excited about that. And then there's going to be another trial with, for actually hormone receptor positive breast cancer with the same vaccine. And those are the 2 trials that are funded, and I hope they'll be both open within sort of a year timeframe. But to Dr. Lee's point, to get funding, and this is a homegrown vaccine that's been developed at University of Washington's Cancer Vaccine Institute, so I didn't have to go seek out drugs. But to get funding and to actually design the trial and execute the entire protocol with all of the approvals that we need to do institutionally, like the scientific review board, there is the institutional review board or something called scientific review committee, so SRC and IRB, these are all like just letters, but it goes through lots of different eyes for very good reasons for patient safety. But it can take 1.5 to 2 years to actually get the whole thing executed. But we definitely have trials in the pipeline with cancer vaccines. And we are working close together with the breast group. And hopefully all of these trials will be available to anybody who's interested.
I do want to be cognizant of the time, but just, I fear we may be getting too far into the weeds, but if you can explain in just a few sentences, because I know that vaccines can be confusing and that this is not a vaccine for people without breast cancer to not let them get breast cancer. This is not like a COVID vaccine. This is a vaccine that's for people who already have the disease, correct?
For now. We are going to go into the prevention space, but we're not there yet.
But the clinical trials that you're talking
The
about.
clinical trials that I'm talking about are specifically for patients with metastatic breast cancer. So with existing breast cancer, not, to prevent breast cancer.
We have one more question.
I don't have a question, a statement. I was in a phase 1 clinical trial, so I don't want people to be afraid of phase 1s. And I'm on my first line treatment, and it was actually to work in conjunction with my first line treatment. And maybe it helped, maybe it didn't. But I mean, unfortunately, the clinical trial ended due to a lack of funding abruptly. And somewhere in here, my nurse practitioner from my trial was here. But don't be afraid of phase 1s because they're not all about the fight and taking over. They could be to work in conjunction with what you're already on. And I had minimal side effects, and it was, I mean, time consuming, but that was it.
Thank you for sharing that. That's great to hear.
You. So congratulations to everyone. You have made it through.
Oh, we have one last
Oh,
question.
okay.
He's got the
Okay,
mic.
okay.
I'm the CEO. What is the difference between palliative care and hospice care? I've been told that especially doctors are kind of touchy about this subject, trying to sell you on either one, not that you guys do that. But yeah, what is the difference? Hospice care is kind of like, this is it. It's the end. We have no more options. Palliative is we're getting ready to get you ready for that phase.
No.
Oh, good. I'm glad
I
I'm
would
wrong.
say- So the difference, hospice care
Good
is a very,
question.
yeah, it's a great question. Hospice, and let's, if people have to go, I know that we're running over and this will be our last question. And before everybody exits, I just want to say thank you so much for coming. It's just been a joy to see everybody and to interact. So, hospice is a very specific service that is offered in the setting of a person choosing for whatever reason, but it is often because they are feeling very tired or they have a lot of symptoms, or usually because the disease has progressed beyond a point where we can continue to treat with cancer-directed therapy, where we think it probably is going to do more harm than good to, say, give more chemotherapy. And so if the person has reached that point and they're choosing not to pursue cancer-directed therapy anymore, then hospice services are often appropriate. And hospice is a variety of different kind of services that get activated, including, and it is focused on end of life. But the idea that somehow they just like hand you a bunch of morphine and then you're like half comatose for the rest of the time is can be that is a misconception. Really, the focus of hospice is to evaluate your goals as a patient and try to see within the constraints that you have, to what degree can we achieve those? How can we let you be as alert and pain-free and enjoying life as much as possible, whatever that may mean. And it really depends on how sick and how symptomatic you are when you enter hospice. Sometimes people are very sick, very symptomatic, and there's not much that they can achieve that, that besides us trying to control pain and symptoms. But a lot of times people will enter hospice and then they'll like live their lives and, go to the grocery store. So that's it. Hospice is a variety of services, but what it means is that we have discontinued cancer-directed care. There are other parts of the world where you can activate hospice and palliative care and all those services at the same time that you're focusing on cancer-directed care. But given our situation and the care, the medical system that we live within, insurance will only pay for either cancer-directed care or hospice. So that's where we are. If we've stopped cancer-directed care and we're thinking that the person may be moving toward end of life, then they can be referred to hospice. That's hospice. Palliative care is a whole range of things, but it is basically a group of doctors and nurses and nurse practitioners who are all focused on helping you achieve a better quality of life, whether that's through symptom reduction, if you're feeling short of breath, if you need, if you're having a lot of pain that is, you're not tolerating pain medication, so what do we do instead? So all about helping you with symptom control, and helping you achieve a better quality of life. Your oncologist only has so much time, and so, you can't talk with them necessarily every time about all the different symptoms that you're having. And so sometimes they'll want to refer you to palliative care so that you can really have an in-depth discussion about, here's what's really keeping me from like enjoying my life and doing the things that I want to do. But palliative care, more and more, people are referring to palliative care with heart problems to help with, you don't have to be terminally ill to seek services with palliative care. It's just about symptom management. The reason the two sometimes get sort of conflated together is that palliative care often will care for people as their treatments change, as they progress through various phases of their disease, and they help shepherd you into the end of life as you reach that point. So they kind of, and we also, I think the onus is on us to refer to palliative care and help communicate with folks about what palliative care means. And I don't think we've always done such a great job of that. And so oftentimes we do refer to palliative care as people begin to get more sick. And so it gets associated with end of life, but it is not necessarily, doesn't have to be that. In fact, I think we need to do it. And also, honestly, palliative care is underfunded. And so it's hard to get as comprehensive palliative care services as we would like. But in an ideal world, every person who gets diagnosed with breast cancer, pretty much at any stage, who is going to undergo treatments that have side effects, I would love to have all of them be seen by palliative care. That can't happen just from a practical standpoint, but I do think that it would be good to refer all of our metastatic patients to palliative care, because all of our metastatic patients live with symptoms and they live with all sorts of things that could be palliated, meaning, palliation just means to make things better, to ameliorate something. Palliative, it shouldn't cost anything. Insurance should cover palliative care.
So we are officially done with the questions. And we wanted to congratulate each and every one of you for coming and participating in the first ever Fred Hutch Metastatic Breast Cancer Conference. And questions throughout this time.
Thank everybody online. We're really grateful to the folks who showed up. And also, we want to hear your feedback. This is our first time doing this. And so anything that worked, didn't work, any suggestions you have, please take the survey and let us know.
Oh, yeah. Yeah. So if you want to have this conference again, I think would